Welcome to our pre-conference on economic policy, on economic analysis for HIV policy analysis. This pre-conference draws on the experience of a crowd of people who have been involved in providing, who have been involved in providing economic analysis to on HIV policy advice for 10-20 years. We in particular, we want to look at two areas. One is on the experience of delivering and receiving economic analysis in HIV policy, and the second area is the implications of the changing shape of HIV, the changing context, the changing shape of the HIV response for economic analysis, and in this interplay of economic analysis, changing circumstances, and delivering and using economic analysis, thinking about how to make HIV economic analysis fit for purpose, how economic analysis is responding to changing circumstances and needs. We have the pre-conference is divided in 4 parts. In the first parts, we focus on the experience of using economic analysis, and that is led by Calypso, who has also who represents the Global Fund, a major user of economic analysis, but also has been a leader in health technology assessment in making economic analysis more useful in informing policymakers through the International Decision Support Initiative. And she is joined by several people representing perspectives from Treasury, from national health institutions and academics working in countries implementing HIV responses. The second session is devoted to responding to the changing needs as HIV is evolving into a chronic disease, which has implications for the needs of people living with HIV, but also has implications for how to analyze HIV interventions, because the time frames getting longer and longer. HIV putting people on treatment no longer averts immediate deaths, but has implications that can last over decades. In the third session, led by Gesine, we are looking more specifically on the role and contributions of modelers providing economic analysis in the region to policy and the interplay with policymakers. And in the final session, we are more forward-looking, and we bring together 2 strands of work, and also like to have a discussion on going ahead. One of the presentations is pulling lessons from the economics of HIV project that the Gates Foundation has convened to take stock and then formulate needs on economic analysis for HIV. And the second one is from Matt Kavanagh at UNAIDS, and he is talking about using economic analysis in shaping the UNAIDS agenda on HIV and inequality. And with that, I like to hand over to Calypso.
Good morning. Right, so I've got a few slides to start us off, and then I'll ask Valerie, Mark, and Daniel to continue. But I can't remember the title of the slides. It's okay? Okay, excellent. And I move them from there. Lovely, thank you very much. Thank you. Can I sit them from there? Okay, well, maybe I will stand here facing them. Okay, so as Marcus said, as a user of economics, health economics, some thoughts, just to have a couple of slides, if I can move to the next one. Am I pointing? I'm pointing everywhere. Pointing that way? This way? Yes? Okay. Well, perhaps it's not, doesn't seem to be working. Maybe you could you just, is this the 1 or 2 slides? So if you could do the next one, please. Or I can come over. Sorry, too early, no coffee, no tea, no. Yeah, oh, fantastic. Okay, excellent. So, well, I thought, why is economics useful for us? So I've thought of 5 things. I'm sure there's more. I hope there's more. First of all, starting with assessing impact. The Global Fund, the partnership, the countries we work with use economics to make a case for investment. Now, there's some issues with that, and I've just flagged a few. So the traditional approaches to estimating return on investment have been quite successful in terms of globally raising money for the HIV response. At the same time, I'm not sure we've been that successful. Of course, we've got Mark here, and South Africa is quite an exceptional country in that sense, and Valerie, but I'm not sure we've been that convincing towards ministers of finance when it comes to demonstrating that these savings are real, or bankable. And I think in the current financial climate and moving forward, at least in the next few years, becoming a bit more convincing will be of the essence if we want to continue or prioritize even more investment in health and specifically in the response. And there's, of course, the traditional, everybody's aware of the issues with willingness to pay and the value of statistical life, and the skewness against people who are poor. Now, that said, we'll hear from Marcus on innovative new approaches to assessing the value of investing in preventing HIV mortality, the impact on distribution. I think that's really exciting work that he'll be talking about. Plus, again, some of the work Marcus has been driving on HIV as a chronic disease and how extending this time horizon has an impact on how we assess the value of investment, because HIV is indeed a chronic disease. So that's the first bit, and I think there's a lot of new stuff to think about, and we ought to change the way of thinking about impact if we want to continue being relevant in this space. Another big bucket of things, R&D, the big debate on local manufacturing here in Africa, market shaping. I've sort of grouped a number of different things there, but Marcus mentioned the work on health technology assessment, and I think people coming to this conference are very much interested in this, and it's wonderful to see a bit more of a convergence between the crowds that do traditionally health technology assessment, benefits package design, and HIV economists. And this is about informing, for instance, advanced market commitments, market shaping, informing the design of benefits packages and essential medicines lists, pooled procurement at different levels. And And I think from the perspective of the Global Fund, what I think is quite important, the conversation we're having internally, or I'm trying to have internally, is that if we have a price insensitive funder, perhaps that's us, though things are changing, and a price sensitive national budget holder, we have a problem when it comes to sustaining the response. And the more we become aware of this, and perhaps economists, researchers can help us understand how to grapple with this. First of all, understand why this is a problem, because I'm not sure this is widely understood, and then what we can do about it. And it has everything to do, of course, with shaping the markets and with driving investment in R&D, and specifically manufacturing here in the African continent. The third group is about integration systems thinking. Now, it is linked to HIV as a chronic disease, for instance, but I think we're increasingly, and certainly the Global Fund, we're increasingly looking at investing in primary healthcare, making a case for investing in health systems, strengthening what we call RSSH, resilient and sustainable systems for health. And that's quite important. I mentioned earlier via the sort of the HTA angle, the importance of integrating both populations and interventions into national health insurance schemes and benefits packages. That doesn't mean that we can expect countries immediately to finance this, but at least seeing this becoming part, this HIV-specific interventions and for people living with HIV, for instance, the same for TB, malaria, seeing these interventions, these populations included in benefits packages and national health insurance schemes where this exists, is important, even if this means that funders such as the Global Fund finance through national health insurance schemes. In fact, I think that's quite important too, as a financing intervention to strengthen financing systems. The frameworks of thinking of HIV as a chronic condition and allowing for integrating gains and losses as people live longer, trying to think about that longer time horizon, I think is quite important. And then exploring issues of fungibility. There's a lot about whether verticals have been crowding out domestic spend. I think it's very difficult methodologically to demonstrate causality, what came first, whether we finance systems that are poor or whether us financing these systems means treasuries pull money out. Perhaps it's probably somewhere in the middle. But nevertheless, we need to think of ways to describe this phenomenon and try and understand it. And currently, I don't think we're there yet. It's quite a heated debate, and we're not engaging in a sort of constructive conversation on how fungibility can be, whether we care about it, first of all, and then how it can be described and addressed if we do think it matters. Then a large group of activities related to the macro trends and financial sustainability. At least at the Global Fund, traditionally, the last 20 years, economies have been growing, both donors' economies and countries we work with. And so it's been domestic resource mobilization has been a little bit on autopilot, even if countries were in some cases deprioritizing health and perhaps the national responses, because the pie was growing in absolute terms, there was more money, there was low inflation, et cetera, et cetera. But now in the current macro fiscal shock we're experiencing with inflationary pressures, devaluation of local currencies, shrinking or reducing rates of growth, or even shrinking GDPs, things are changing. And on top of all that, countries are also deprioritizing. If we're seeing what's happening in terms of allocation, for instance, for 23 budget allocation, it seems that health is being deprioritized and losing out to agriculture, education. And within that, we're not quite sure what's happening with disease spend, but perhaps that's also being deprioritized. And the value of what money buys you is also important, I think, and that's also affected. So being able to understand this and getting economists to talk to us and describe this is quite important. Plus the latest of the Bridgetown Initiative and the evolution papers of the World Bank and MDBs. I was on the sidelines of the Paris Summit a couple of weeks ago, and climate is increasingly internalizing health as a game. And the climate financing ask is huge. And I don't want to pitch one against another, but it is quite important. We might end up seeing, for instance, malaria being very much a climate issue or an issue related to growth or poverty, which is very much the case. But what does that mean in terms of financing? the response to malaria and the role of MDBs and fifth, such as the Global Fund in engaging MDBs. And then finally, can we link inputs with outputs? I came to the Global Fund, I thought we would do more work on value for money and efficiency, and it's been really difficult, not for a lack of trying, but it is hard, primarily because we have very limited visibility on who's funding what, let alone then linking these financing flows with the results. But it is quite important that we do more of that. Okay, the next one, I think I have one or two that they're not as dense. I'm pressing this, but it's not well. Okay, excellent. So I mentioned the issue of integration. I think it is quite important. This is some work that was done by CGD just before I left, or after I'd left. It's been published, funded by the Gates Foundation. But basically, the colleagues looked at benefits. Yes, thank you. Sorry. Benefits packages in a number of countries, and in very few countries, HIV interventions were included. And in any case, those packages very rarely updated. So that is a problem, I think, as we're talking about universal coverage and sustainability. And the next one, please. Okay, well, I mean, I think economic evidence is useful. I think it's being increasingly used. We have the Global Fund, a new technical brief on value for money. We've updated it. We've done some evaluations of how well we're using health economics. On the right side, you see the relatively new Africa CDC Health Economics Program and the newsletter, and I think that's important. And then on the left, I've just put there, I think it's a bit old now, but it's extremely topical, this work that Justin Sandifer and Amanda Glassman did, thank you very much, on data and how data should be relevant. And this very much applies to economic data, relevant to decision making. And the final one, my wish list. So I think it would be great to do more, and we are starting to do more, working with PEPFAR, for instance, given they have a new co-investment strategy. They're very much seriously talking about scaling down towards 2030. So how do we tackle this? How do we work together with national budget holders to think about this transition, if it is indeed for real, which I think it is? More visibility of financial flows, I think, is really, really problematic when we don't know what's happening in terms of financing. Some people say, well, it doesn't matter, we just look at results. But looking at results is also hard. And I think that leaves us in a situation where we're sort of flying blind. Methodological innovation, I mentioned fungibility, the work Marcus is doing on equity. How do we measure health system strengthening? We struggle a lot, the Global Fund, with how much of our money actually strengthens health systems, how do we count it? And this economics framework that's more integrated and holistic, I think, will help us do that, as opposed to pitching one against the other or dividing. And then capacity building, working with the likes of Africa CDC and regional national institutions to strengthen health economics capacity. And I think, so this is still not working. I think that's it. I think, if I recall. Okay, so being the chair, I'm now going to ask, I think we've got, is it Valerie? Would you like to, do you have slides? Excellent. Okay, fantastic. So is the plan, Marcus, to? No? Yeah? And do you have Daniel? Yeah. Oh, you have met. Very interesting. Please, would you open? Here, maybe? Okay, so it's nice, small group of us. So why don't I start with asking you perhaps to share some reflections? Thank you. I'm sorry I didn't catch up.
Good morning, everyone. My name is Valerie Obare. I work at Ministry of Health, NASCOP in Kenya. NASCOP is our technical lead for HIV response. It's been a mix of success, but currently in the space of sustainability, transition, and budgets, you start to reflect, are we ready as a country and what does this mean for us? So just the first perspective of where we are and in terms of programming currently, as much as we have domestic funding contribution, it largely goes, what you can account for in terms of when we do the funding landscape, we are really able to quantify our contribution towards commodity procurements. But traditionally, the governments have built facilities, they've employed healthcare workers, and that, how does government quantify its contribution to a particular disease? Because half of its contribution goes, the health budgets goes to the whole system, it's cross-cutting, as much as there is deficiencies and we're still struggling with that. So I think in this current conversation, often we probably underestimate what the governments are doing towards a particular disease because it's cross-cutting. And as we move forward for these conversations and rally the government to fund more, the value for what the government is funding needs to be quantified in a better way. Don't just take the linear budget for that year, $40 million, and say that's what, it's suboptimal because I'm bringing 300. There's the historical contribution and all that, because it really probably makes the government wonder, okay, what then have I been doing with all my money? Does it mean the Ministry of Health is not even using the money that I'm doing? More so when we have to then engage with the Treasury, because they are the institution that then plans for us our midterm planning and all that. So there was a conversation around HIV investments is life-saving, it's all this. When we were having very, very high mortality rates, it was the clarion call and people reacted to it. In our country, we have 94% treatment coverage. Mortality has gone down, incidence has gone, like it looks really good response. So there's an inertia sort of, because cancer is killing us, NCDs are killing us, diabetes is chaotic, road accidents are chaotic. When you go to the table to request for funding, you can't use the mortality anymore as a clarion call. So how do we package HIV to continue being an important investment? Because we know as soon as you turn your eye on the goal, we will reverse the gains that we have seen. So it's really important for us, and as ministries, we need to see going forward, how do we anchor HIV-based response within the context for what we are currently? Primary healthcare initiatives, universal health coverage strategies. There's the bigger agenda for health insurance cover that the government is doing. How do we then build our case, align with the government strategy for us to move forward? There was the conversation around allocation of funds from Treasury budgets, and I think I've alluded to that. We increasingly request for funding, but what the government is able to see is what goes to procurement of products. How do we make commodities affordable? Initially, when commodities come in, they're quite pricey, they're not in the local markets. There's really a request around building our capacity for local manufacturing. Most of our African countries struggle probably because there isn't enough investment in the field for local manufacturing for pharmaceutical and diagnostics. It's always seen that it's something that we will get from the Asia countries for us to import. One of the things that economists in Treasury see as local manufacturing being an opportunity, then you can say investing in HIV makes sense for them. It means you can produce those things in the country. You're creating jobs. You're retaining the funds within the country. And therefore they feel that is something more of an investment case. Why can't we do these things? You are the clients, you have the market. What is so difficult? So that is our challenge for the next cause. What can we produce within our countries? We've been able to produce other pharmaceuticals that are of quality, and therefore we see that as an opportunity to spur economy. So if we are talking about economics of changing, HIV changing economics, that's really a tangible area they see as something that if we invest in, even if you're doing test kits within our local markets, you're creating employment, but also you're the pressure we usually have around exchange rates and all that inflation, it secures the countries in terms of then their stability for economic space. Then I think we cannot run away. PEPFAR, Global Fund, everybody's talking around issue around sustainability and transition. At the same time, the countries are saying we are recovering from COVID, we are having inflation. So just a balanced discussion so that it's not rushed and every country can be allowed to see its context and what it takes, because COVID really impacted on physical space for many governments, but beyond COVID, there's also the historical issues around debt for what other sectors had already invested in. We had a lot of infrastructure bonds and all that. So we hope to see a conversation that is balanced, but also allows for governments to be on the table to chart the way forward and to be able to negotiate a transition mapping that is feasible for the country. If this is not done, I think there's usually the inaction and then it turns into an out-of-pocket expenditure for the client. So with that, we can all assume or at desk level say, no, the government is ready, transition. But inherently, the person who bears the cost, you start to see bigger proportions of out-of-pocket expenditure that directly then gets picked by the clients who receive these services. So thanks.
Thank you, Valerie. Thanks very much. Mark, shall I?
Okay, thanks very much. Good morning, colleagues. Yeah, thanks, Valerie. I really agreed with your points. I thought they were really excellent. So, I mean, South Africa has over 5 million people on ARV treatment now. And I mean, economists, some of them who are in the room, you know, really played a massive role in the response, in developing the early response. And I mean, if you remember, the early days of HIV were a bit like the early days of COVID. I mean, it was a complete crisis. And everybody was worried about it. It was a huge political kind of issue. It was a health catastrophe, et cetera, et cetera. But if you look at COVID now, I mean, in South Africa, for example, people don't even want to talk about COVID. I mean, you know, a year or two back, we were desperately scrambling to buy vaccines. Now the Department of Health is looking at how they destroy unused vaccines, for example. I mean, it's a complete change. And I think the situation with HIV, although not as dramatic, it is also a massively different landscape. And so I don't think one can continue in the same way that we've done before. And I mean, the economists have done an incredible job in our country, many other countries. I mean, they developed investment cases that pushed the spending. They did massive amount of cost effectiveness analysis as every new intervention came into place to assess it and then bring it in and cost it and fund it, and developing NSPs and the costing, the budget bids and the monitoring, and supporting the governments and the donors to work together on common paradigms because they speak different languages and so on. So it's been a massive amount of work. But I mean, I think we need to recognize now that it's 20 years later, or 10 or 20 years later now, and the paradigm has changed completely, and we need to change what we're doing. And it's quite difficult to change to new paradigms. So some thoughts about the way the work needs to change. So although, you know, some of these issues are still relevant, like, you know, there are going to be people countries that are still developing NSPs, and they need to know the funding gap, and particularly while there's still a lot of these big global and bilateral donors who want very disease-specific stuff, there's still, you know, is a call from them for, you know, all these kinds of things, developing budget bids and so on. But the terrain is changing, and I mean, it's no longer for most countries a question of should you treat people with HIV or have funding for people to treat. It's like obvious you have to treat people with HIV. I mean, you can't send people who, who've got HIV home, so, it's putting a lot of emphasis into that is not kind of quite the right question at the moment. If one looks at the way the funding landscape developed in HIV, in the early days, treatment was really expensive. I mean, phenomenally expensive. And so donors came in an absolutely massive way and put in place a funding infrastructure, an administrative infrastructure, which was huge. In many cases, kind of displaced the entire potential government response because they fully funded them. And so now what you see 20 years later in many, many countries is, those countries would rather spend their own domestic budgets on their own things, because the donors are funding all those things. But the costs have come down massively. And effectively, we need to plan transition, which is, it's not a question of, whether governments want to take over the funding of HIV, domestic funding of HIV and the management of the programs. It's like they have to do it. Politically, they have to do it. They have to do it because of it's the human rights, from a human rights perspective, a care perspective, a primary care perspective, a UHC perspective, every kind of perspective, they have to do it. And so the question is that the key question for me is how do we restructure the current financial incentive arrangements that governments have to do the right thing. It's not whether they want to do the right thing, it's they have to do the right thing because that's just what has to happen in the new environment. So, the reality is in the 10 to 20 year history now, one can't continue just to have separate vertical programs for every disease, for COVID, for HIV, for TB, for malaria. They can't all be totally separate. One has to look at primary care in a more integrated way, chronic diseases in a more integrated way, and increasingly kind of the leadership that economists gave to HIV. And in South Africa, for example, I mean, HIV has been the strongest program and the biggest program, but increasingly those same skills are being called upon to guide the other programs and other programs that have to be integrated into it. And, those same economists have been said, well, you're the person who knows how to do that, but now can you do this? Because, we know you can do this, but can you do it through these other things as well? And also the more integrated broad picture. So the issues of primary healthcare costing, package development, equity, district funding formulas, the benefit package design, the health insurance design, the inclusion of HIV in benefit packages and insurance schemes. I mean, these are all kind of critical areas of work now. I mean, the examples that Calypso gave of, 2 or 3 countries who actually don't even include HIV in their benefit package. I mean, I did make this point in the meeting, the London meeting. I mean, to me, it's kind of an example of a totally failed incentive arrangement. It's like, it's the worst possible incentive you could have for, the donor funding. It's almost like you've got to completely restructure the funding that, if we don't build a kind of collaborative arrangement built on government funds, well, we don't fund this because, that's the way the thing's got to be basically structured. And obviously it has to transition, whether it's 90, if it goes from 90-10 to 10-90 over 10 years or 20 years or 2 years, depending on the country, obviously these things have to transition. But I mean, things have to change effectively. I think maybe I could just make one other point is that on the prevention agenda, there's still kind of quite a lot of unanswered questions. And if you look, for example, specifically in South Africa, we have about 62% youth unemployment, which is what South Africa's unemployment rates, I thought they were the highest in the world actually until apparently Nigeria has recently surpassed South Africa on unemployment, but on youth unemployment, I think but South Africa is like the highest in the world. So the problem is how do you prevent HIV, for example, when you have 62% of youth who don't have anything productive to do every day? I mean, so the whole question of how do you look at young people's lives and their productive lives in a more kind of comprehensive way, but also, think about sexuality education and economic incentives and participatory activities and things like that in a broader context. I think sometimes some of our responses perhaps have been, although the questions of effectiveness of specific responses is very important in their cost effectiveness, but the bigger questions of the location of youth development is quite a relevant issue in South Africa at the moment. I mean, we're struggling, for example, at the moment, we have a new social grant we introduced in COVID called the SRD, a 350 grant, which 8 million, mainly young people get now. What do we do with this? Because people are sitting at home getting a payment, but they don't do anything. Anyway, so those are some thoughts. Thank you.
Thanks, Mark.
Thank you and good morning. Daniel Moy is my name. I'm a health economist. I come from Kenya. So I think I've spent my years working on generation of evidence from the economic evaluation perspective. I lecture at the University of Nairobi, the health economic unit that is part of the capacity development. So I also look at it from that perspective. And currently an advisor to the president of Kenya on health. So I would also want to marry all that thing. So I've seen when I generate information, I want people to use. I've got to a place where I also want to use the information generated. And the question we need to ask ourselves is, why is it that probably we don't do the things we have written we should do? I keep asking myself, yet we have evidence generated. So from the economic evaluation side, I would think that one issue I see is that there is huge acceptability of the costing, all right, as a base economic evaluation component, and all programs you'd find they use this data. They want to, because they'll be forced to anyway do the costing, all right? Sometimes they'll not use it as it's supposed to be, but at least they use. But when I look at the issues of cost effectiveness analysis, efficiency analysis, equity analysis, there is absolutely very little acceptability of these, results to use them. Actually, the results are okay. They are well estimated. They are fantastic. They are giving the right direction, but there is no acceptability or desire to actually go to that route. One, because probably you're suggesting a pathway that is not of interest to the so-called the policymaker. So they choose regardless. So over the years, I think I started working on cost effectiveness analysis back in 2010. And I think I've seen less than, 10% of that work, being translated into policy. So one thing I feel is that for randomized control trials, perfect. It is used there. More because it is used, by the researchers, by the funder. They want it done, they want it proved, and then it ends there. Now, transitioning to government and also making it to make impact, it's still low. Now, is it an issue of acceptability? Is it an issue of rigidity by government not to change? Are people fixed in the area, towards the pathways of how they have been working over time, and therefore they are not willing to move that direction? So that's my experience within these countries in the region. So the data that is generated, well, it could be right for purpose. There are many times that we do costing for researchers and institutions and ourselves. Now that make the data to be yours anyway. And that is why you'll find that for a long time, the costing data has not even listed the countries of origin. And therefore, nobody trusts it because you can't access it when you need it. And if you cannot access it, you don't trust it. You don't have a champion, in-country champion for the analysis and therefore for the policy use. Some of which we have done analysis without even the participation of the country, ministries of health, for instance, or the national AIDS control programs, or the HIV control programs at the ministries. So if this data is analyzed this way, my experience is that the likelihood of its acceptability, even when the data is solid, it's become very low. Now, the willingness of HIV, program, another vertical program, to sit down with others is also a difficult, actually, because these are brothers that have been rich for a long time, So they have just discovered that they need to collaborate now and they have been living a good life. So they want to collaborate with programs that ideally had no funding, but they want to collaborate at their own terms. Now that's a problem, because the costing as developed for HIV program, when you move towards integration, then we need to find acceptability and, concurrence in also, accepting the other programs and how they run, so that the program become, inclusive of the others, so that you kind of meet the need of the HIV program, as well as the integration equation, where many times we are going. Now, the other thing I have discovered is that the data we produce have a very little passion and emotions. When you talk about death averted, that should make you worried. When you talk about incidences that are not, that didn't happen, at least people are happy. There is some emotion. And majority of the people working in the health sectors actually come from clinical side, all right? Some of which do not appreciate whatsoever the issue of numbers that look like costing numbers. So that make it difficult a little to actually accept this number. Actually, in a country I was in like 2 weeks ago, actually, the issue they were discussing global fund interventions that are at the LSSH, some of which were actually related to costing interventions. And then one clinician is saying these activities have no passion. There is no emotion in them. They are flat, right? So I was telling them, you have chosen the wrong implementer, because there is a person with the right passion and the right, emotion towards the activity. Now, what I'm saying here is that acceptability depends on who is leading, who is interpreting, which is their training, and do they see the policy utility of that data. Now, the more the rigid the government is in terms of change, then it becomes hard for data use. I would think that what I have learned is champions are critical, champions of use of data. So we have very few champions in our in this region of Sub-Saharan Africa, which have good horizon of what happens. So if there are no champions on use of data, people will still use data, but it's not quality data, and therefore I think there is great desire towards reorienting the policymaker that could be, for instance, in my country, I would talk about the county representatives, who the budget will go to them anyway for approval, but they don't understand anything, right? So when we have economists generating the data, it goes to a small, kind of assembly that probably has very low understanding of why it is important to use that evidence and what can it do? What does it mean in the real sense? So I think champions could play a bigger role in government, like people who like numbers are oriented to become the champions of data use in those institutions, so that when a bill comes to parliament, the finance bill comes to parliament, there are champions in there who understand the use of this data. They have a history of how it can be deployed to actually make sense. Now, the silo costing that has been going on for the HIV program, malaria, TB is important. Now, within the integration equation, then realism becomes very important. And we need to move to becoming more realistic as we make the essential benefit for packages for health, what can be absorbed in the initial time in terms of the burden and the cost of the package that can be included in the initial, as the countries probably transition and mature to become more stable and have more resources, probably even post-COVID time. So the question that I ask myself is, what is HIV that we can absorb, right? Now, that means that the data should also be broken down in a way that there are components of HIV that can feed into the essential benefit in the short run, medium term, and long term. So if this data is not presented like that, as it is now many times, then we find that people just throw HIV out. It's expensive For sure, you know, the certainty of spending is one. So there is no pooling of risk, it's certainty. So you find that people would not be willing to take each of these components, including the prevention components, which are largely not costed. So the other experience is that we have been curative and happy in costing those areas, but the prevention agenda was forgotten a long time ago, not only by the implementers and the clinicians doing the programming and managers also, but also within the financing domain. Very little money have been pushed that direction. Little costing are funded towards that direction. And therefore we have less evidence that is useful for policy, so to speak, regardless of whether people wanted to actually accept. The government contribution as estimated within our countries, and more so for HIV, which is largely multi-sectoral. I do believe that the costs we have are largely health costs, and we don't go a lot into looking into what the other sectors have actually injected within the HIV programming. And I'm talking about the multi-sectoral component here. What's education doing to keep girls in school? And when they keep girls in school, evidence is clear that these girls will have lower incidences. They will also have, you know, they will reduce the chances of having early marriages, for instance. But these have transitions into the health outcomes. But how far do we go to look at those as government investments that have been done beyond the direct? But on one side, we talk about HIV being multi-sectoral. We have agencies that are ideally founded on the basis of multi-sectoral coordination of HIV response. But when we look at the costing, we don't capture the other areas, all right? Some by design, of course, to tell the government you are doing so little, put more. But also it's important to give the whole picture, so to speak, for governments to be able to accept. The last thing I wanted to say is that also how much are we willing, not only the government now, but also the development partners to accept the truth. So my role was to share my experiences. So I'm just highlighting the things I've seen. So the funder as well, both government and partners, there are so many times they're not willing to hear the truth. And for several times we have learned value for money analysis showing absolutely no value for investments that are done by the key funders that we have because of the way they have channeled their funding. And 3 times I have been told, please don't publish. 3 times, all right? Don't publish by serious people, serious institutions, some represented here, right? But we are here talking about economic evaluation that should be able to read the policy. So who are we reading? The government only, or are we also supposed to reorder our thinking to a mode of evidence designed towards changing our mode of Peladi, the way of our doing things? So I find quite some, rigidity in changing to actually, even when evidence is available, generated by yourself. Actually, one study was funded by the one who refused to use it, all right? And the reason was the way they were channeling their money was actually not providing value for money to the country. There are other options that would have been done that actually guarantee that you get better results from that. So when I look at these issues, I think, yes, economic evaluation is useful. It is used by different people in different ways. However, we must be very realistic and agree that data is data. It can cut both sides. It can say you are doing very well. It can also say you are doing very bad, all right? And mainly, numbers rarely lie. It's just that people lie with the numbers, all right? So we need to become more proactive in using data and also accepting that data is for change. Thank you very much.
Thank you, Daniel. Okay, so we've got some time for discussion. I'm not going to go through and highlight what people have said. So it's a small group. Please feel free to ask questions, express your views. This is working. It is. Ideas, please.
Hi, my name is Dash. I'm a health economist at the South African Medical Research Council. I lead the Youth Health Economics focal area at the MRC. My question to the team is, many of us now are getting funding in HIV for economic evaluations of HIV-related mental health, well-being interventions in the country. Of course, when it comes down to presenting that data, average cost per outcome change is really high. My question to Mark and the others is, how do we present that to government, especially, you know, how do we also anchor those field-based implementation studies in the way that they would also buy into this, given that there's also a need to look at these broader issues of the HIV response? Thank you.
Thank you. Thank you. Perhaps other comments, questions?
Hey everyone, Matt Kavanaugh from UNAIDS in Georgetown University. So I'm curious to hear, picking up on Daniel, your point about midway through that very helpful and very insightful talk on prevention, and thinking a bit about, what we could have seen in the most recent period was a real revolution in prevention, given the technologies that have been coming through. But we haven't seen that revolution in prevention. And part of that is about how we're using tools and about for whom we're using tools and at the scale at which we're using tools, whether that be the biomedical tools or the social intervention tools that we know are working now. Because to your point, the evidence is really clear on what's working. So I'm curious about, especially to colleagues in government, how are you thinking about the prevention piece? Because this ends up being, of course, also the space where we've seen transition, it becomes the biggest point. Your point, Mark, on governments are going to, one way or the other, pick up the costs of treatment. Whether or not those will be the best regimens in the end, and as we see progress, whether that will continue is a big question. But prevention pieces tend to fall away, some of which are really effective, some of which are not. But that question is I think, a huge challenge as we think about the future. So how are you thinking about those, the role of economic analysis and what more is needed for government in that space as we go? Thanks.
Okay, well, maybe we take this. How do you present evidence? I think, Daniel, your view as well. But I'll start with Mark and then.
Okay, thanks very much. Yeah, look, I mean, I think that the question about research translation is an important question. I think in many settings. I mean, I think in South Africa in the early days, there perhaps was more openness to working with academics and economists than, perhaps than in many other programs and areas. And I think there are, in many contexts, there are real difficulties with this. And I think that, I mean, there are many reasons for this, but I think trying to think how one embeds research into services and policymakers is really important, because researchers and policymakers they tend to speak different languages. And whereas there are many attempts to bridge those gaps, often they, in some ways, fail. And I mean, in South Africa, I think we have some examples which are very successful. I mean, I think our Treasury tries to engage with researchers, perhaps more than some other treasuries in certain areas. But we've also seen huge failures of the ability to engage. I mean, if I can just give a practical example, we have some leading academics in South Africa in mental health, some world-famous mental health researchers. And they have found it impossible to actually get their proposed investment cases for mental health and analysis considered or implemented or adopted. So, this issue of trying to, bridge research work and government is a very important question. But I do think, trying to work closely and on an ongoing basis with the decision makers and to understand their needs and their problems is important. I mean, it's very sad to see excellent research just not being used. I think the importance of economic analysis in prevention work in HIV is an important, actually unanswered question to some extent at the moment, because I mean, whereas I think in the HIV space, there's always been kind of a kind of dream of the kind of magic bullet, but which has been kind of very elusive. But I mean, there are kind of suite of potential interventions, some of which are, partially being used, but not others. So I think there is need for more work in that. And the prevention area has always been tricky. I mean, Cassine, I think, had very interesting experience in the early days of the South African investment case where, I mean, one of the things Treasury, the Ministry of Finance in our case, liked about the investment case approach is rather than having to deal with, from a budgetary perspective, with 30 separate budget bids for every aspect, the investment case weighed them against each other. So Cassine ended up like excluding 24 out of 30 and only including 6 in the investment case, because those are the only ones which met her very tough economic evaluation standards. But of course, the relevant ministers didn't like that. So they put in a lot of others ultimately, and that watered down a lot of the things. So, I mean, prevention has always been the kind of under-researched, poorly understood area of it. And it's partly, of course, because of the complexity around sexuality. But yeah, I think that is an important area of work.
So shall I pass it to you two, and then we can close, right, Marcus? Yeah.
So just quickly around the question around mental health integration and how do you make policymakers more responsive? I think at the design phase, there's usually a tendency of people planning. We all have access to what are our challenges. So you plan, you actually do the research, you come with results. Then everybody's like, oopsie, okay, how do we start with this? If you understand the context also from the ministry's perspective, you are able to tweak certain things. But as you've highlighted, there are different ministries we sit. It's not just health, it's the multi-agencies, and everybody has their ticket item that they bring on the table, and sometimes it makes it more complex. Integration of services is going to be our new area for learning. I don't think there's anybody who knows if I do one TB, malaria, HIV, if I put them in one room, is that integration? If I have one user fee, is that integration? I think that's the area we are going to learn. So for prevention, and in our context, for example, in Kenya, we have both biomedical and social interventions, advocacy being very, very key and has been largely funded. How do you translate all these investments and now say, this works, this doesn't work? That hasn't been very clear. What metrics do you use? Our vulnerabilities to new infections are largely driven by poverty, lack of knowledge, not knowing your status. It's complex. You cannot say, I'm going to address poverty in a scheme of 1 to 10. He's just spoken about unemployment. Really pertinent issues that are drivers of risk of new HIV infection. And beyond that, it also affects mental health. People who are desperate, they tend to also have mental health challenges. So I don't know if it's in the scope of one day or this day that we get to answer that, but I think that is the ongoing challenge that we must work with to see then how do we design our prevention interventions in a manner that makes sense.
Thank you. And to close us off.
Yeah, thank you very much. I think 2 things I want to highlight. One is that for independent researchers working on economic evaluation, I think how we generate those questions also become important, because sometimes we generate our own questions, we answer them ourselves, and we want them to be used. All right. So how the prioritization of what is being done comes into play, even within the local research institutions, for instance, they should be responding to a certain demand of an analysis that is needed, for instance, but you can also do it for curiosity, purpose, for your own, like discover something. Now, if that happens and your work is not used, it's not bad. The intention was for your curiosity. Now, if, on the other hand, the generation was driven by demand towards influencing a certain policy, then automatically you have a higher chance of that data being utilized. However, I don't believe in high costs. It's nothing like that. Because when you're doing costing, you are doing the cost of what's happening. I mean, if it's $80, it's $80. If it's $1,000, it's $1,000. So there is no high cost, low cost, because for me, you have generated the data, you have used the right methodology, so it's not high. All right. So what's making it to look high is because people don't understand it. All right. Now, so the issue is, for me, is of presentation. And we did work recently in Kenya on prevention for AGYW, And when we engaged the national program, the first thing they say, these numbers are very high, all right? And we said, we are also thinking so, all right? So what do? Let's sit it down together. Let's go through. Let's see what is off. Now we go into breaking down the data into different cost drivers that ideally make people understand what's in there. Now you realize that, well, a unit cost is very important. From where I look at it from, I don't like it. Because just give you a number, $10,000, all right? And for somebody who have never seen $10,000, they say very high, right? For somebody who have been seeing a lot of $10,000, they say very low. So which is high, which is low? So now that decision become a discussion that you won't get results, so to speak. But I think we must become very meticulous and systematic, actually, in the way we present the cost data, in a way that it speaks to different audiences. So the one audience would be required, who is doing cost effectiveness analysis, would require probably a unit cost to feed into the model. Somebody who is doing programming would want to understand, among these levels, what are we talking about? What's making the 10,000? All right, what constitute the cost? So I think the presentation become very important, so that one cost doesn't have mental health, the other one has mental health. One will be high, the other one will be low. So I think this is the kind of discussions we need to start having, more so as we inform integration, because integration will happen in phases. All right, so some things will be integrated, others will not. So when you roll out a mental health program in country, it will not say, we will not put that, for HIV patients, you are not included, all right? So you'll say a mental health program, which will cover both those without HIV and those living with HIV, all right? But they will pick a component only of mental health, for instance, which is part of the cost. So you start making some progress towards integration. So I think for me, the investment around the prevention must center around household. The prevention agenda will never be successful until we integrate and we look at household as one. Because the household that, again, have a HIV patient or client is still the same that have somebody who have a mental health issue, actually. And it will have a child requiring PMTCT, and it will also have a mother who is pregnant and require to be prevented malaria and such a thing. So we must look at the unit on analysis for prevention as a household. Then from there, we inbuild different prevention packages within the same approach. Now, the verticalization of the HIV program, we have mentor mothers, we have peer educators, we have 1 million people going to the household to tell them, I have arrived to give you good service, and, do whatever you're supposed to do. Now, this household is the same for my country. For instance, we are launching community health promoters, which are covering the whole country and the whole households. So you ask yourself then, how do we move towards not also disturbing the household? You want to go and farm your land in the morning, a CHP has arrived. By the time, after 1 hour of taking their tea, then you find a mentor mother has arrived. After that, you find the one tracking whether you are using nets have come. So you find that you are disturbing households in our approach, so to speak. So I think we need to look at integrated models that provide prevention pathways in a more cost-effective manner. And lastly is that the funders of this must first accept that that is the direction. Because you change the way you channel money, you change people's behavior. But if we keep on saying integrate, if we keep on saying, let us have a comprehensive prevention agenda, but we don't change our funding approach, then it remains, an achievable dream. And that's why I think we have a big, big problem. So we need to invest in evidence for prevention. It does not look very nice. Sometimes it's abstract, You're telling people, these are the people who would have gotten sick, but they didn't get sick. I've not seen that. They have not consumed any medicine. So they were not sick anyway. Maybe they were not to get sick. People can generate all manner of, ideas to counter the prevention agenda. But the more evidence we get into that loom, the more we bring the finance data in, the more we mix finance and epi into this, then the better we get results. And I think we move towards a more cost-effective, efficient, and even achieve better equity within our programming. Thank you.
Thank you. Thanks very much. Thanks to the panel. I think structuring the financial incentives in a way that works as opposed to in a way that doesn't work is one of the several takeaways. Thanks very much. And to the panelists, over to you, Marcus.
Okay. Thank you. And I'll just continue the conversation, and I'll be speaking to three of these themes from the previous speakers. And one is to Mark, yes, it's 20 years later, and the questions asked, the challenges, the shape of HIV have changed. I'll be speaking to the challenges of developing, formulating investment cases and capturing the returns to investments in the different dimensions of investments in HIV. And I'll be speaking to measuring and building advocacy on prevention effectiveness. And the one answer I'll have, partial answer I have to these questions is through better economic modeling that captures the transition which has taken place over the last 20 years of HIV into a chronic disease. Next. Rather than the situation in which for example, the government of South Africa found themselves that people were imminently dying of HIV, I myself got into looking at HIV as an economist at the IMF, and the situation back then was a desk economist for Swaziland. How do you assess fiscal sustainability in a country where 25% of the population were expected to die within some 10 years? And that is not the situation we are facing now. Some thoughts on the modeling side of that. HIV, even before treatment became widely available, has been characterized by a long lag between infection, AIDS, and death. In the early stages, HIV tended to prevent, ART tended to prevent immediate, imminent deaths. Even then, conventional policy analysis tended to cover some fairly long policy periods because some of the effects through HIV incidents then feeding back into treatment needed some time to build and to capture some of the longer survival. To capture some of the survival effects more fully, but longer survival because of HIV, ART incurs recurrent costs, which are not well captured in models if they just look at what happens for over 5-10 periods of investments in HIV, looking at the deaths averted. Yes, they gain life years, but those current treatment costs. So HIV models tend to work around this, building longer time horizons, which capture the health effects and also the costs more completely. But the drawback of this approach is that if you adopt longer time horizons, actually what you get out of cost effectiveness analysis gets much more imprecise in terms of what is actually the cost effectiveness of what you are doing now. You are no longer informing current policies. You're providing an average of an assessment of what HIV policies on average over the next, say, 10 years are going to achieve. And with treatment coverage going up, with HIV incidence, HIV prevalence changing, the cost effectiveness of the cost effectiveness of intervention is changing. So these models, these longer term models, they are very imprecise on, in particular, allocative efficiency. And these challenges have become worse because widespread access to treatment has changed the dynamics of HIV and of the impacts on interventions. One is treatment initiation tends to occur earlier in the course of an infection. So we no longer have a situation where there is this primacy of getting as many people on treatment as quickly as possible, and getting additional people on treatment, going from a treatment coverage rates of 80% to 90%, because most people who urgently need treatment already receive it, has a very small impact on mortality. So an HIV policy analysis, say to 2030, captures very little effects of the captures very little of the survival gains of getting additional people on treatment. And the second consequence is that provided that treatment is initiated sufficiently early, people living with HIV have a good chance of surviving to old age. So rather than preventing imminent deaths, capturing much of that within the conventional policy horizon, what we are looking at is HIV infection getting people on treatment, resulting in changed mortality over the next 10, 30, 50 years. Somewhat people living with HIV on treatment having mortality which is maybe 1% higher, which is still much higher than background mortality. But these survival gains, these mortality losses, they are spread over a long time. And again, attaining these survival gains is also subject to a recurrent cost, which is spread over decades. As a consequence, the conventional model focusing on deaths averted and costs over some fairly long policy period, maybe 2030, has become even less precise, less fit for purpose. So the next. So the objective, there are two objectives to the work I'm speaking about today. One is build a model that consistently accounts for losses in life years and costs of HIV, and accordingly for the effects of intervention. So that's that theme is making models more precise in terms of capturing the costs and consequences of HIV interventions, and through that providing more precise policy guidance on allocative efficiency and inform HIV policies. And there's a second objective, which in part derives from the first, but also is separate: build a model that yields improved estimates over shorter time horizon. National strategic plans of HIV, they are typically formulated over 3, maybe 5 years, but economic analyses supporting these plans, they are almost always formulated over a much longer time period, and so they don't directly speak to the decisions on HIV intervention, on the allocative efficiency of investments taking place within the time period of this National Strategic Plan. And in order to achieve these two objectives, the method is, in addition to counting the costs and gains in life years from deaths averted during the policy period, which is what the conventional model does, we capture the loss in life years and the treatment costs of the population living with HIV at the end of this period. So the map, the space in which we are moving, we have the conventional model, which includes the costs to year X, say 2030, and the deaths averted to year X, and in different forms then on it is common to specify the returns to investment in HIV, building on these deaths averted in terms of life years, in terms of what kind of output gains people who survive as a consequence of these investments achieve. But in addition, including this conventional model, but in addition to what is captured by the conventional model, the chronic disease model captures two things. One is the projected treatment cost for the cohort living with HIV in year X from year X plus 1 over life. So in this sense, this echoes some work done earlier on the liability, which is implied by getting people on treatment. And also this model captures the loss in life years to the population alive with HIV in year X. So for a person on treatment in say 2030, it captures that, yes, this person has a fairly good chance of living to old age, but life expectancy still is 5 or 10 years lower than for a person not living with HIV. For a person who is not receiving treatment in year X, it captures, yes, mortality is higher. This person may or may not go to treatment over the next years, but we can incorporate these prospects and estimate the diminished life expectancy and also the projected treatment cost for that person and add it into this mix. Neither of these two models are complete in terms of capturing the effectiveness of investments in HIV, because they do not capture what the impact, what the implications are of changing the shape of the epidemic. So if a country successfully pursues a policy of ending AIDS, getting HIV incidence much reduced, it could be possible to then sustain these gains at a much lower cost. What neither of these models captures is the long-term cost and health consequences of this shift in the trajectory of the epidemic. So both types of models tend to underestimate the returns to investment in HIV. Methods, it's modeled in Python. It's designed to run on output from spectrum goals to complement conventional policy analysis directly. I pull estimates on people living with HIV on and off ART deaths, mortality with and without AIDS, overall program costs, ART unit costs, all coming from goals. I use background of derived, that doesn't come directly from goals. I derived in this model the breakdown of AIDS mortality into mortality on and off treatment, drawing rich data from the model through regression, which is integrated in the model. There is a function for annual transition to treatment from year X plus 1, and this function is fairly flexible, but in the analysis I present today, it's a very simplistic, I use a very simplistic assumption. 10% of people not living with HIV each year transition to treatment. I take I take the costs and deaths averted to year X from spectrum, project life year losses and treatment costs from year X plus 1 for the cohort alive in year X, and then derive estimates on cost effectiveness analysis, both for the conventional model and for the chronic disease model. The model is implemented using 2022 spectrum goals, 2022 spectrum goals file for Zambia, supplied by UNAIDS, who have not otherwise been involved in this analysis so far. I calculate the cost effectiveness for policy period from 2021 to 2030, but I also, in light of the second objective, I also look at how the results change for shorter periods and how these different models behave. First, on the conventional model, implementing meeting targets relative to constant coverage to 2030 requires, in Zambia, requires an additional investment of $615 million, which averts 25,000 deaths, which are equivalent to a gain of about 1 million life years. So in this sense, investments in HIV attain a cost effectiveness of about $570 per life year saved. In the chronic disease model, implementing targets relative to constant coverage changes the size of the cohort living with HIV at the end of the policy period. And there's basically no change in the number of people on treatment. And the reason for that is, yes, in the under meeting targets, there's a much faster transition of people not yet receiving it on treatment, attaining higher coverage rates, but at the same time, HIV incidence declines, and because there's fairly fast transition of people who become newly infected with treatment to treatment, then these effects, say, roughly cancel out. So the number of people on treatment by the end of this policy period is roughly unchanged, but reduced HIV incidence does very clearly show up in the number of people who are not yet on treatment in 2030, which declines by 85,000. As a consequence of that, we can calculate the loss in life years, the diminished life expectancy to the implied by the change in the population on treatment, because there are somewhat more people on treatment in 2030. There's a loss in life years of 125,000 years, and the reduced number of people not yet of treatment achieves increase in life years of about 1 million. So there is a net gain in life years of 950,000 for the cohort, for the population alive in 2030, in addition to the impacts that we have already captured through the conventional model. There is a there is a change in the cost of lifetime cost of HIV post 2030 of about 6 million, because there's more people already on treatment in 2030, but that is more than offset by the a change in the cost of ART to the population not yet on treatment in 2030, which is a saving of 122 million. So implementing this assumption that I have put in here, 10% annual transition into treatment, the larger population of people not yet on treatment also contribute to the saving in this ART liability. Cost effectiveness, comparing conventional model and the chronic disease model, whereas in the conventional model there is a cost of $615 million. There is an offset to this cost through reduced ART costs beyond this policy period of 116 million. So costs declined to by about 1/5 to 400 to about $500 million, incorporating this saving. If we, but the largest effects are if we look at the gain in life years. From deaths averted through 2030, we get 1 million life years. For the population living with HIV in 2030, because much fewer people get infected to 2030, there is another million of life years saved as a result of the investment in HIV. So the total gain in life years doubles to about 2 million. And as a consequence, what we get out of this chronic disease model is a cost effectiveness of $250 or $247 per life year saved, which is less than half of what we get out of the conventional model. Almost all of this gain comes from consistently accounting for the gains in life expectancy of people who get on treatment earlier, or because they do not become infected with HIV in the first place. Now coming to the second model, the second objective, which is making HIV models better fit for informing national strategic plans, shorter and providing more precise information on the allocative efficiency of current investment. What I do here is I present the results for different policy periods. So what I have focused on so far is the cost effectiveness of the conventional model and the chronic disease model to a time horizon of 2030, which is located at the very right of this figure, $550 or $570 versus $250. If we look at shorter time horizons, the models diverge much more strongly. For example, going to 2025, the chronic disease model returns cost effectiveness of about $300, whereas the conventional model only returns a cost effectiveness of $1,200. And so in the conventional model, if we look at the time frames of national strategic plans, which now would go, say, to 2025, 2026, it is, well, the conventional model doesn't really provide meaningful estimates of the cost effectiveness of these investments, but the chronic disease model, because it consistently accounts for the gains from reduced HIV incidence from year one, is able to capture these longer, evolving effects and provides much more precise and meaningful estimates of cost effectiveness of HIV policies, even down to time horizons of only 3 or 4 years. So a discussion, well, a couple of points for discussion. I argue that the chronic disease model is much more satisfying than the conventional model because it consistently accounts for the consequences of HIV infection and cost of keeping people living with HIV. So HIV infection is a bad thing because it damages health, reduces life prospects, results in recurrent health costs, and the conventional model doesn't really consistently capture this effect, and so it provides more complete, more precise estimates of the cost effectiveness of HIV policies, and it is able to do so over shorter time horizons. looking ahead, much of the differences between the conventional model and the chronic disease model that I've presented comes through valuing HIV incidence, the returns to investment in HIV prevention. So there are potentially significant implications of this work, not only for program analysis, but also for allocative efficiency analysis, in particular on prevention components of HIV programs. And that is something that I will be looking at, but have not done yet in the near future. Thank you. Now we have a little time. We are already in our allocated time for the break, but if you have more questions, I'll be happy to answer them now. Otherwise, we'll reconvene in about 20 minutes.
We have time for questions. Do you have to break, or we shift to the third action?
We'll shift to the third action.
Thanks very much, Marcus. This is the first time I'm seeing the results of that. I know you've been working on this chronic disease model. I have two technical questions. And so we've been taking notes about, I think it is an extension to our modeling framework very well worth considering, including for South Africa. I have two questions. The one, I noted that you discounted cost but not outcomes, which is a diversion from standard methodology. I know you're the first author of a paper on discounting, so I'm very certain there's a good reason for this. However, I would imagine that it has a bearing on the huge difference in results on outcomes between those two types of models. So I'd like you to comment on that, if possible, justified. The second one is, I think, so the question of where to right censor your outcomes, especially in HIV, but generally in health modeling, is, I think, as old as us modeling health outcomes, right? And I think over the years, we've kind of landed on basically you right censor whatever you can justify. However, you have to do it consistently across all the interventions you're comparing. Now, I think with this whole application, you're moving HIV into the realm of now being compared with other chronic disease interventions. That's the idea behind it. Yeah. So basically what I'm trying to say is, I think all of these are valid. However, we have to then do the same with diabetes, hypertension, cancer, et cetera, interventions, which we're currently not doing. So right now, your ISA is a little bit, isolated, I think, in terms of being useful to inform policy on where to spend chronic disease money. Perhaps you can comment on that as well.
Thank you. Thanks to the previous presenters as well. It was a two interesting session, and best is yet to come. I get awkward moment. Then okay, Marcus, when you assume that 10% of people who need treatment don't access treatment, right? Can I understand this like we're not reaching the 95 targets in your model, and we still have a 10% per year, which is with composed interest over 12 years of planning period, much more than the 95 that should reach by 2025. That's my first question.
It's a transition rate, so it's actually a bit faster than what meeting targets is doing. So it's 10% of people not receiving treatment transitioning to treatment each year. And that is a transition rate that gets you to a very high treatment coverage rate, and actually increasing from year 2030. And I've experimented with different transition rates in this simplistic uniform setting, and it doesn't have a big impact on the results because it works both on the numerator and the denominator of this cost effectiveness ratio. So if you assume a lower transition rate, yes, the gains in life years decrease, but also the costs of attaining these life years. On Gesine, well, part of your comment I read as this work has become much clearer, because when I described it to you on an earlier occasion, you said you didn't get the point of it. So something has changed, and it's also my thinking is becoming much clearer on how to use this kind of analysis on the role of discounting. Yes, I've presented undiscounted life years, because that is in terms of framing these results, that presenting that in life years saved, or translating to sort of global burden of disease landscape, which is also using particular form of life years saved. They would use undiscounted life years. The model is set up, and that is one of the extensions that I'm currently implementing to incorporate a discount rate. I have done some rough calculations, say without treatment, then cost effectiveness would be reduced by about the difference between the models would be reduced by 1/4. If you look at higher transitions into treatment, well, there are two components. Part of the difference between the conventional model and the chronic disease model comes from the accounting for cost. That doesn't change, because that is already discounted. So the results would survive even a larger markdown for discounting the drawn out effects of recent HIV infections on health, but I'll be able to provide a much clearer answer in a few weeks. And yes, on diabetes, etc. But at least if you look at intervention analysis in chronic disease, you frequently encounter life cycle models, much more so than in HIV. So in that sense, the chronic disease model is a move towards adopting methods which are common on chronic diseases. I'm not so sure on the time frames which are commonly used in diabetes or cardiovascular disease analysis. You can educate me on that. Thank you. Did you have...
Okay, thank you very much for joining us after the break. My name is Gesine Meyer-Rath. I'm from the Health Economics and Epidemiology Research Office at WITS, University of the Witwatersrand. I'll be chairing the next session, and I'm also starting with the first contribution in that session, which will be looking very concretely now at using modeling for informing HIV policy in high HIV prevalence countries, with the examples of South Africa, which I will cover, and Zambia, which will be covered by my colleagues Valentina Cambiano from University College London and Isaac Taramusi from UNAIDS, in fact. Both of which have worked extensively in Zimbabwe. So I think how we'll do this is I'll go through my slides, and then Valentina and Isaac can go through their presentation. We'll take questions and discussion jointly afterwards, if that's all right. Where's the slide progressor? Okay, perfect. Could I have my slides? No, that's not them. I wish I could talk to it, but I can't talk to inequity analysis to save my life. That's it. Okay. All right. So I'll be talking about the experience, not so much of myself, but of HERO in general, on how we used modeling to basically create the perfect data to policy to budget cycle. And I'll make you the judge of whether or not that ended up being perfect quite in the end, but cycling certainly we did. As I said, my affiliations, just to quickly, is mostly at HERO, but I'm also on the faculty of Boston University School of Public Health and affiliated with CIMA at the university, at Stellenbosch University. So this is how this cycle works like. We start with cost estimates that are either generated by HERO or by other people. In the case of HIV and TB, we have access to exceptionally good locally developed epi models in the shape of, for HIV and TB, Tembisa, a model developed by Lee Johnson at the University of Cape Town, which most recently, or which has provided HIV estimates for the South African policy space for a good 15 years, and most recently has also added TB into it. That goes down to the provincial level, and then for the district level, we have most recently had the addition of the Naomi model, a model developed by the Jeff Eaton and colleagues at Imperial College London, much rather. Those together, so the EPI model and our cost estimates then give rise to cost effectiveness analyses of all and sundry. Every single HIV and TB intervention, I think, of the last couple of years has been has had a cost effectiveness analysis behind it. And this then, in a good year, gives rise to a selection by government of optimized intervention targets and basically intervention lists altogether in the shape of investment cases. This then gives rise to policies and guidelines, and of course to national plans, including national strategic plans. And this in turn informs the budget. And now you can get the idea, this is a cyclical process. It turns around once a year roughly. A budget is only as good as being able to inform the level at which it is being spent. So we, after doing national budgets for HIV and TB, break it down into our 9 provinces in South Africa. We then sometimes, most years not, also have national, provincial level plans that are implementation plans for the national strategic plan. And very, very importantly, again, a budget is only as useful as you're able to track the expenditure towards it, as well as track the performance towards your intervention targets. And that is being done at the provincial level and informs in large parts the implementation itself of each of the HIV and TB interventions at the provincial level. This then gives rise to new service statistics, which in turn inform a new baseline for our EPI models. And as you can tell, this is an exercise that involves a lot of steps and a lot more than just HERO. So you can see HERO kind of is involved in the cost estimates up there, but so are a number of other academic institutions in particular in South Africa. But in terms of every single other step, most of that is actually borne by the Department of Health at the national and provincial level. And there's a good number of other partners. SIGA is an NGO that helps us with the budget execution tracking in a very intense kind of way. And of course, there's SANAC over here that is involved in the NSP development, et cetera, et cetera. So it's not us, it's us and a small army. HERO has, however, probably contributed the bulk of what other people like to call average unit cost estimates, what I like to call average service cost estimates over the last couple of years. And this is just a summary of all the intervention unit costs that we have been able to produce. As you can see, for HIV, that covers everything from prevention over diagnostic to treatment. We have over the years probably costed every single way of giving ART to different populations, including now differentiated models of care. We have also on the HIV prevention side, which people are perhaps least aware of, recently costed opioid substitution therapy. We've done both the oral and the injectable PrEP. For TB, we have also very recently produced a new set of cost estimates for every single thing you can imagine. And again, the novel interventions there are mobile chest radiography, TOTT for all kinds of populations. So that's targeted universal testing and treatment for TB, as well as all types of treatment regimens, including BPAL. That's the most recent one. On the prevention side, we've costed 3HP. So I'm saying this mostly if any of you are in the room looking for any of these cost estimates, come knocking. We share them. We sometimes have them on our website, but since they get updated so regularly, often those are slightly outdated already. So just shoot us an email and we'll share what we got. During COVID, all of us on in the Sun had a third job. So instead of just doing HIV and TB, we did COVID as well. So we've been costing all the vaccines. We've informed the testing algorithms and the many, many changes to it. And of course, we've done a whole lot of cost effectiveness analyses of the treatment options that were all led by Lisa James and my colleague here. STIs we've covered a little bit. And these are a number of basically then non-infectious disease interventions that we've also covered. We've costed a lot of cervical cancer diagnostic and treatment options, breast cancer, same thing, lung cancer, smoking cessation, and a couple of additional ones. And for diabetes, mellitus, and hypertension, we've most recently concluded a systematic literature review of primary cost data in South Africa, rather than doing our own estimates, which will be probably a next step. Just to give you an idea, so HERO produces these cost estimates. We almost always do them bottom up. So we kind of get samples of patient files, essentially abstract resource use data from there and cost the whole thing up, rather than doing, top down or ingredients costing wherever we can. For novel interventions, we often do ingredients costing. But in any case, we always consider the most recent salaries and public sector costs, etc. So the cost estimates tend to be the freshest you can get on the market. So the next step then after the cost estimates, if you remember, the cycle was getting EPI model estimates, and a little bit more on the two models we're using for that. Tembisa, as mentioned, is developed by Lee Johnson at the University of Cape Town, produces HIV and TB prevalence, incidence, intervention coverage, and impact over as many years as he wanted, so he can model into eternity virtually. At the national and provincial level for HIV and at the national level for TB. This is one of the typical outputs, mostly showing how, in this case, while ART coverage, the total number of people on ART and ever started track the actual data. And that's the website under which all of those results are available. And Tembisa is updated annually, as I mentioned before. So right now, the estimates from version 4.6 are available. They're pretty fresh. They've just been officially signed off on in June. Naomi takes these estimates to the district level. Naomi doesn't project into the future. It's really very much a kind of spatial estimation exercise. Naomi is an exercise that was funded by UNAIDS for a great number of African countries, but the South African version was the first. So we kind of helped the team establish basically principles there. And it produces basically these estimates in South Africa with the 52 districts of, in this case, prevalence, but also incidence and ART coverage. I think also MMC coverage is now on the website by age and sex. And there's another output where you basically have the districts lined up by their, in this case, also ART coverage. And that really helps in order to see which of the districts have already reached, in this case, I think the second 95 target, or the tracking towards that. As I said, those two models, it's especially Tembisa actually, Naomi not so much, but Tembisa is a model that we use for all of our cost effectiveness analyses. Sorry, this is the website under which the Naomi results for South Africa are available. So we use Tembisa as well as our cost estimates to then do our cost effectiveness analyses, and all of them come together in an exercise that we have been running since 2015 on an annual basis, which is the HIV investment case. Last year we've started doing the same thing for TB, but this is just for HIV. Essentially, it comes up with a long list of interventions that in this case are ranked by cost effectiveness. This is not a normal league table. It's there's an optimization process in there that has a rolling baseline, so it's slightly more, let's say, complex than a normal league table. There's papers to take you through the methodology. It doesn't really matter for our purposes now. But what's really important is that we basically say, this is the most cost-effective list of interventions ranked by cost effectiveness of spending HIV funds in South Africa. And then we compare that to the available budget. Now, when we did it in 2016, we kind of said, you can only afford this set of interventions. And that was our constrained optimization scenario. And if you have more money, you can start going into these. At the beginning, as always, condom provision is the most cost-effective intervention. It's actually the only one that was cost-saving. Actually, not true. Circumcision was also cost-saving back then, and then the others in order of cost-effectiveness. when we redid this, so we redo it annually, but just to kind of give you an idea, in 2021, for example, there were a number of additional interventions that had come to the fore that we didn't have effectiveness data for before. And we also looked at, you can see the order is roughly similar. So condoms are still the most cost effective, followed by ART. Circumcision had dropped because we had a much higher baseline coverage, and the others kind of distribute very similarly with a number of additional interventions like HIV self-testing and PrEP added at that stage. However, when we looked at the budget, we actually found that year that all of this was now affordable under a much increased HIV budget. And this is not completely coincidental, but because once you have that cycle going and you use your budgets or your modeling to inform the budgets, it was unsurprising that the budget actually covered all of those interventions, at least if we were content with just achieving a second 95 target of 78%. So 78% ART coverage, which is what we were kind of basically going to achieve by 2025 at that stage. Then we looked at what would happen if we actually were serious about the second 95 target and kind of aimed to achieve that by 2025. The order of interventions change a bit because we now add, where is it? ART, yeah, the ART linkage intervention in there. Everything shifts out a bit, but it also means that if we now look at the budget that was then available, it would actually only be sufficient for a number of interventions, and 3 of the least cost-effective interventions would actually drop out and require additional budget allocation. The point here is, and I just want to kind of quickly correct something that Mark mentioned earlier. When we first did this, we did start, with a suggested list of 43 interventions, and we only included 16. That is true. It's not quite the numbers that he meant. This had nothing to do with Gesine Meyer-Rath's special criteria, whatever. The biggest drop off between the 43 and the 16, the only drop off was because there was no effectiveness data. So it's nothing to do with cost data. We always make up cost data if we need to. But if your intervention is loved by you, implemented by your NGO, you're really pushing for it, you think it has worked, however, you don't have data to show it has worked, there's nothing we can do with your intervention in our model. We might love it too, but there we are, we can't make up your effectiveness. If we put it in the model based on assumed effectiveness, it will just produce exactly what you told us it would. There's no information gained out of that. So that was the biggest drop off, not having enough effectiveness data. And just to the point we were discussing earlier about prevention, as you can see, we have a whole big chunk of prevention interventions, both in the first run and certainly most recently. If there's trial data very often for its effectiveness, we will put it into our model, and we will do lots and lots of sensitivity analysis about, how that trial effectiveness might actually play out in real life. And we've done that most recently, both for oral PrEP, but also for injectable PrEP. So that's one of our most recent applications there. Okay, moving off this. Next step is then to inform national plans and budgets. And that's just a quick timeline. So basically, since the beginning of HERO's existence, we've been providing cost estimates. Even before that, the Tembisa precursor, the ESSA model, also developed by Lee Johnson, had been informing basically targets, etc., planning for the HIV response in South Africa. There's been a lot more updates to its basic annual version since more or less 2011. After that, now Tembisa version model, Naomi came in around about 2020. We have been consistently since 2006 doing these cost outcomes and cost effectiveness analyses. There are too many to mention here, but basically every single of those interventions has had, as I mentioned, a cost effectiveness analysis behind it. We've been running these annual HIV investment cases also since, well, the process started in 2013, but outputs from 2015 also on an annual basis. And we have managed to inform kind of at least 3, I think, sets of ART guidelines, or 4 actually, the 2 most recent PrEP guidelines, well, the only PrEP guidelines actually, and 3 sets of NSPs every 6 years, informing the next 6-year period. Yeah, that's that. And then throughout and continuously since 2008, we've been informing those budgets at the national level, a year later at the provincial level. And then for the last 11 years, we've been having this basically closing the loop on the left-hand side, as you saw, of the cycle by budget execution tracking. And that's just worth another little slide, because it's really quite a complex process. It involves the 9 departments of health in each of the provinces, but also increasingly at the districts, which are now supposed to do a lot of the HIV and TB planning and budgeting at that level, which means a lot more manpower or woman power going to each of those offices and on a quarterly basis to kind of work with them on whether or not they've been able to spend the budget that they have had pointed to them, and what their outcomes are, and to be able then within the budget year, to course corrections if either you're overspending or underperforming, which is it's a heavy lift. It is something that government should be doing on its own. The people who are working at SIGA to do this very much work alongside government counterparts. All of the meetings are kind of jointly chaired by SIGA and the government, but there is just not enough, human resources within government at every level to do this continuously on their own. But sorry, the last thing I'll say on this. So Calypso said earlier that if we don't track our financial flows, we are flying blind. And not only in my idea are we flying blind, we also have no idea how much fuel is left in the tank. So that is a fairly catastrophic situation, which in South Africa we've been able to remedy somewhat over the last 10 years. And just 3 last claims on 3 couple slides to show what might have, perhaps as a result of this, but also independently, what happened to the HIV budget. Basically, when we started with this work around about 2009, it had been growing, and these are real terms, kind of more or less linearly. And then as a result of us being able to model how many people there could be on ART, in particular if eligibility was increased, and how much cost, so unit cost, could be decreased, we were able to show how much the budget should, informed by these 2 numbers, should increase. And the allocations were, in fact, so that's the final allocation here, were increased according to what we said. So the dotted lines are our projections, the red line is what was actually committed, were increased to those levels. So that is one of our first pieces of work from 2009 onwards, informing those budget amounts for 2010 to 12. And ever since, that same process has worked. This is the period we just looked at, but ever since, basically, we've had these more than inflation increases to the HIV budget, until most recently, where under COVID, there was first an increase in the allocation, which was in part for COVID-related services. And then as a result of the shrinking fiscal space, as a direct result of COVID, we've, for the first time now, had defunding of the HIV conditional grant in South Africa. Now, this is a worrisome picture if you remember that South Africa funds 20% of the global HIV response from domestic resources. So this is basically, if you combine this possibly with the defunding of the global fund and a somewhat uncertain future of PEPFAR, I'm just saying none of us know who will be in the White House beyond the end of next year, just reminding ourselves of that. This is a potential crisis. For the first time in modeling HIV costs in 20 years, I'm alarmed. And I think so should all of us be. So then last 3, sorry, this is not very well said, but the last 3 slides on, so I can stand here claiming that HERO has made some difference to how at least HIV and TB are being budgeted and planned in South Africa. What do the others think? So just before COVID, we managed to squeeze in a series of key informant interviews with 22 experts working with or in the South African government, that included 11 data users, so at the side of the government or PEPFAR, 4 other data producers, so cost data producers in academia, and 7 who were sometimes were both using and producing additional data. So that were people like from the Clinton Health Access Initiative, etc. We asked them to both tell us what worked and what didn't work, and start thinking about solutions. The results of those, just 2 kind of juicy quotes. I really love sometimes qualitative research because it brings out these kind of gems that you otherwise would never have heard, or certainly not on record. where one producer user essentially said that the Department of Health does not have a health economic unit, as we are totally reliant on the technical assistance we are getting from development partners such as HERO. That is not technically true. The Department of Health, in fact, has a health economic unit that is doing some work on especially pharmacoeconomics, has been picking up this tab quite a lot since, but is otherwise fully and utterly under-resourced to do all of this work on their own. And another one saying, you know, there's always some international consulting company that wants us to use their flip-in model, I'm quoting. So I took great delight in insisting that it be whatever local institutions work to be used instead. This is just mostly for myself. So the recommendations coming out of that exercise, so those 22 people, key stakeholders that we asked for barriers, but also suggested solutions to more cost data use in particular, they named that the quality of an access to cost and program outcome data is still incomplete, especially outside of HIV and TB, and suggested things like publicly available cost data repositories. So we've done better on that, but also increasing the availability of programmatic and outcomes data at the aggregate level. We're working towards that, or government is rather that it should be available publicly. Government in South Africa and everywhere else is struggling with making outcomes data fully transparent for a number of reasons, but I think only one of them is not wanting the scrutiny of independent sources outside of government. They identified problems with technical capacity, generally with cost and economic evaluations, both kind of doing them, but also understanding the results. And I think Daniel spoke to that when he said that people like the cost data, but they hate the cost effectiveness data because that might already be beyond what they can easily understand and penetrate, which of course plays it back to us. We need to explain these things better, but also here that might not be data that actually informs decisions because it's just a little one tick to abstract perhaps, but also that data was still insufficiently often used, and for that we suggested a stringent system of HTAs essentially, which is something that's now has been happening in the last 3 years in South Africa, especially as we move towards our version of universal health coverage. And also what we wanted to push towards is, and that's not happening yet, but will probably soon, to have a set of primary decision criteria that are transparent and applied across all health decisions, including possibly cost effectiveness. And lastly, more of a governance issue, that there was suboptimal coherence and collaboration within government, both between the national and the lower spheres of administration, but also in particular between Treasury and Department of Health. That is an ongoing thing, especially also at the lower levels because of very high staff turnover. So whoever you train tends to then leave for a better paid job in the private sector because they are duly trained. So that is unfortunately something that happens a lot. And basically what we want to do, apart from continuous training, unfortunately, is to improve the link between national and provincial planning and budgeting in particular. All right, so the last, and I'm sorry, these are so badly set. The last 2 slides, so our lessons learned is basically to say that since 2009, when we got involved in earnest, the country's HIV TB conditional grant has increased 3-fold. Average service costs have dropped significantly also as a part of us pointing to additional cost savings. We have certainly the world's largest HIV program and one of the world's largest TB programs, in which novel diagnostic screening and treatment interventions are routinely made available and scaled up really quickly. And that is, I mean, it should be taken for granted. These things are often developed for countries like South Africa. So South Africa should implement them, but South Africa is also implementing them and paying for it from their own dime, doing all the planning and training and whatever is needed, demand creation, etc., all on its own, which is, it's happening regularly and no one has to kind of keep pushing this process. So that is quite a, big thing. And our interviews showed that there's a high overall confidence with the validity of our methods and results, and stakeholders are generally satisfied, but want to have those methods and those processes expand beyond HIV and TB. And challenges that remain are especially a lack of skills to understand the results, but also produce some of these analyses themselves, especially at lower administrative levels. Okay, my last slide. What we've learned in, I don't know, an easy 15 years of doing this is that this process is either iterative and locally owned, or it is not. And the more time and money in particular we spend and our funders spend in building a workforce and in expanding workforce of Northern Hemisphere institutions that kind of send people on one-off consultancies, the more that comes at an opportunity cost of not having built these institutions locally, and not just individual people trained, but actual institutions built. We know that these planning processes need to be cognizant of local budgeting practices and involve local staff who are already doing this. They have to produce a budget. Either they just use last year's plus inflation, or they're actually building this up from the bottom. And while you're doing it, you might as well, or you need to start from working with those, making sure you answer their questions, and you're using their data sets that are already there. They know the prices, they know the salaries, they know most probably the quantities that are normally used. So work with them, or don't start in the first place. And it has to be incorporated into at the relevant administrative levels. And that is a really important thing for us. We kind of first worked only at the national level for the first 4 or 5 years, and then realized that this had nothing, had absolutely no impact. So we had to go to the provincial and then district level to make a real difference. My main thing is that once-off training is not enough. We have to kind of think about this as a maintenance issue, where we are in country, we are involved, we kind of build all these skills that are used in that cycle continuously, and then we ride off into the sunset, unless we're living in those countries, in which case I'm pretty sure we are welcome to stay. Okay, that's it. There's a whole lot of people who contributed to this. A lot of it was in fact funded from the HIV Modeling Consortium under a project called MIPSA, and Valerie and Isaac will talk more about the same project and how it's implemented in Zambia in a minute. Okay, any questions? I think we'll reserve until the end of the session. Thank you. Vale?
Yeah. Good morning, everyone. And Gezin, are you able to? I'm gonna share my screen, or are my slides gonna be up there? Can you see my slide? And can you hear me? Hello?
Yes, Vale, I can hear you. We can go ahead. I'm not so sure the team that is in the conference room. Thank you.
Maybe Marcus, or before we start, Marcus or Gezin, can you let us know if you can hear us?
We can hear you. Can you hear me?
Oh, okay. Yes, yes.
Okay,
I
perfect.
can. Sorry.
Okay, take it away. Thank you
Great.
very much, Valerie.
Very sorry not to be there in person. My name is Valentina Cambiano, and I'm based at the University College London. And I'm going to share this presentation with Isaac Tharamusi, which is now at UNAIDS and has been doing HIV modeling in Zimbabwe for a very long time. So, and thank you very much, to Gezin and Marcus for inviting us to present the work under the modeling to inform HIV programs in Sub-Saharan Africa, and in particular to share our experience in the context of Zimbabwe. So these are the kind of steps I'm going to go through, but I think let's start. So first of all, what is MIPSA collaboration? So it stands for Modeling to Inform HIV Programs in Sub-Saharan Africa, and is a collaboration between modelers coordinated by the HIV Modeling Consortium and national stakeholders and economists to inform HIV programmatic policy in Southern Africa, taking example setting of Malawi, Zimbabwe, and South Africa. So Gezin and all the people she mentioned are involved in the MIPSA collaboration for South Africa. and is carried out by the EXA Health Community together with the HIV Modeling Consortium in conjunction with the Ministry of Health and the National AIDS Council in these countries. So country HIV program planners face challenges in designing their programs, particularly in the context of likely need for funding transition to reduce donor dependence of HIV program budget. And decisions have to be made on the funding to be allocated to sub-programs such as HIV testing, voluntary medical male circumcision, different modalities for pre-exposure prophylaxis, antiretroviral therapy, and so on. And often this is subject to constraint in both the budget available and the capacity of health system to deliver a wide range of intervention. Social enablers also need to be considered. And so a concerted effort to inform Ministry of Health-led country program design involving input from contributing donors and other stakeholders is likely to be of value. So why using mathematical models? So they are recognized as having the potential to inform such design, but several models exist with different structures. And you will see just for Zimbabwe, we actually have 5 models that are involved. However, unless this is coordinated, they may not consider exactly the same specific question. And so that might be a reason why they come up with slightly different answer. And they might use slightly different approach that are not kind of like evident when they present in a manuscript they are finding. And so a collaborative effort to apply a various model to inform programs has the potential to be insightful with lessons for programs broadly for the region. I think from the same point of view of modelers, I think it's a great opportunity for mutual learning and cooperation. And it really has the potential to advance the field of HIV modeling. And I have to say, in my experience, at least in Zimbabwe, it has been all the modeling teams have been very generous with their time and have been very open to maybe show kind of like the weakness of their models and discuss if, for example, some assumptions are slightly different. And the involvement of stakeholders enables a better understanding of the health system and funding constraint they are working under. So I think it's for modelers, it's important to work so closely with the Ministry of Health and the stakeholders to understand what are the considerations that are taking place. And at the same time, I think the Ministry of Health kind of like learn the process the modeling teams go through and maybe understand why sometimes the output is not ready the day after. So the overarching aim of MIPSA collaboration is to pull insight from multiple models to inform the future design of country HIV programs in these 3 African countries. And these are taken as example. And in so doing, really move us towards alignment of thinkings of multiple stakeholders on future program design and enhance the use of modeling to inform such designs in the future. And in the meantime, when calibrating the models to this country, really identify what are the critical data gaps. So this MIPSA was set up in March 2021. And soon after we realized that actually we had to have a separate sub-project in each of these different countries to really make sure that one of the criteria for example, selected intervention was the interest from the Ministry of Health and the local needs. And so this project was set up in 3 phases. The first one aimed to understand what the different models were predicting for the future, assuming a status quo, and estimate for the past, and understand reasons for the discrepancy. So to make sure we were kind of like on the same page. In the meantime, a viewpoint was published really to underline the perspective on the use of modeling and economic analysis to guide HIV progress in sub-Saharan Africa, and again, making sure that the different stakeholders, Ministry of Health and modelers were working together. And then now we are currently undertaking what we call phase 2 to estimate the epidemiological impact and cost effectiveness of each potential intervention separately in the context of an essential set of intervention for which dropping the intervention will not be considered. And Isaac is going to go in more details about this, this phase. But the rationale was really to go step by steps to make sure we do understand if in the end we come up with slightly different discrepancy, what this might be due to. And then in the final phase, to identify intervention that deliver the most health benefit for the fixed available HIV budget. So why focusing on the HIV budget and on Zimbabwe? And just to say my background, I'm an HIV modeler and a health economist from Zimbabwe work with us on this. But Zim will need to find ways to address donor dependency and ensure the sustainability of financing HIV intervention. And you can see from this slide that HIV funding in Zimbabwe is largely dependent on three main financing sources. And the reduced government funding reflects the constrained macroeconomic situation. So in the short term, there will be need to maximize the technical and allocative efficiency with existing funding. So this slide shows the HIV funding by the HIV intervention area, and not surprisingly, most of the funding has been allocated to HIV treatment, with of course benefit in terms of mortality and morbidity. There is need to determine if ART investment have reached the saturation point. And in terms of prevention that was discussed by the previous speaker, prevention funding at the moment is mostly towards behavior change and voluntary medical circumcision, accounting for almost 2/3, complemented by PrEP condoms and blood safety. And I think as part of the MIPS Zimbabwe project, I think we're going to see whether actually that's the best allocation. Looking at the HIV funding by implementing partners, you can see on the left-hand side that it's really fragmented across different implementing partners. And this kind of is then reflected on the fact that the administration costs are actually quite high at 40%. And I'm now gonna hand over to my colleague, Isaac.
Okay, thank you, Vale. So the country had this in mind to say, how can we optimally allocate these resources that are budgeted for each and every year? So for us to be able to answer those questions, we used the modeling approach where we called for interest among modelers to say, can we have the models that will that can best give us information on the optimal approach and also utilization of intervention with the high impact and effectiveness on the resources. So we flighted a call for modelers to respond so that they do the modeling approach. The first criteria was to look at the transmission dynamics of the model, the simulation of the intervention, and also to report optimal allocation of resources. Then 5 models that responded was the GOES model, the Optima IBM, which is led by Mike Pickles. Then also we had Optima models where we have Sherry and Deborah. We have synthesis model that Vale and Henry is working on, the eMod. The GOES is John Stover, which is leading, and I'm collaborating. Then we have also the country local teams, the teams of health economics, teams of epidemiologists who are also leading the process, like in Zimbabwe with Ngwarai, Vale, and myself leading the process. Next slide. So these models are like what Vale have indicated.
Sorry, Isaac, you're
looking at 3 phases. The first phase, Vale highlighted that, and also, hello, can you?
Sorry, Isaac, you're breaking up quite a bit. Is there any way that perhaps Vale can take over? I think her bandwidth might be a bit bigger. Vale?
Yeah, Isaac, let me know if you can find a place where you have a better connection, and I will hand over back to you maybe. So as mentioned, the aim of phase 1 was to understand kind of what the different models were predicting for the future and estimate for the past. And so the first step was the Ministry of Health and NAC to compile the data on the epidemic and program delivery. And for example, on this aspect, you can see that from the point of view of Ministry of Health and NAC, it's a lot better if they relate to one coordinated effort rather than providing data for 5 different models. And models were asked to simulate kind of the status quo, calibrating their model to a set of essential data that I'm going to show in a minute, and some optional data were provided as well. And then they were asked to project forward for the next 20 years, assuming intervention are kept at the level they reached in 2019-20, in terms of rates of ART and viral suppression, rate of mother-to-child transmission, and rate of traditional circumcision. And you can see we simply ask the 5 model to calibrate to the trend over time in HIV prevalence in adults and the number of adults on ART. But many other data were provided so that they could use, depending on their model structure, to calibrate their model to Zimbabwe. And I'm not going to show the results, but maybe just to say that they all found a decline in HIV incidence, but there was some variability on the size of that decline that we are kind of like investigating to try to understand. As part of the phase 2, the aim was to estimate the epidemiological impact and cost effectiveness of each potential intervention separately in the context of an essential set of intervention for which dropping the intervention will not be considered. And this consideration was done by the Ministry of Health. So we had to define with them the research question, what was the essential scenario, and identify the intervention. And similar to the approach taken by the other country, MIPSA, 4 criteria were used to choose which intervention to evaluate. And this was the interest from the Ministry of Health, good data on the effectiveness, good data on costing, and feasible for at least 2 models to include. Then we had to compile some costing data. And to do that, we worked with a health economist working in Zimbabwe, who had previously worked with the Ministry of Health, and then the model set to the modeling itself. So with the Ministry of Health, actually at the beginning of MIPSA Zimbabwe, we decided that actually what they were most interested in was to how to best allocate HIV resources in Zimbabwe in the next 2 years, starting from 2023, given an annual budget of 418 million. That was the budget that was estimated in the Zimbabwe National AIDS Spending Assessment Report in 2016 and 17. And I think this might be revised actually when we arrive to phase 3. And what they told us is really that what they are most interesting, kind of as Minister of Health, is the minimization of HIV incidence by 2030. However, when conducting our economic evaluation, what we're going to use as a measure of health is disability adjusted life years, looking at 20 years and 50 years time horizon. So from pulling up from what Marcus said, so at the moment, the approach that has been agreed is to use a long-term time horizon to take into account those some of those effects that might happen quite later in time. Isaac, do you think your next one might be better? Do you want to try again?
Hello, yes. Yes, I can talk about the treatment interventions for the second phase scenario, where we had HIV testing in facilities and antenatal care, then the treatment where we are implying the universal treatment where we are implying test and treat for adults and children, then the HIV prevention, general HIV prevention to general and key population, where we have issues like condom provision and mother-to-child transmission using antiretroviral therapy. Next slide. Then for phase 2 modeling, where we are talking of epidemiological impact, we started with the initial modeling where we were going for each intervention by intervention to assess its epidemiological impact. And at this phase, we started with PrEP, where we assessed the epidemiological impact of PrEP, that is on essential scenario plus PrEP to adolescent girls and young women aged 15 to 24 years, targeting up to 2026. So the target that are there, they were the one that have been used to estimate the epidemiological impact of PrEP, where we were looking at the high risk population that have been put on the as the NSP targets, and those who should be also on PrEP as enrolled according to the national guidelines on eligibility criteria. So that was what was inputted in the module. Next slide. To assess the epidemiological impact. So for that, we had 7 HIV testing service interventions that are going to be assessed according to the Ministry of Health and Child Care and National AIDS Council, where we identified 39 candidate interventions, 7 of them are HIV testing interventions. Then we have 1 structural and social enabler intervention, then 21 HIV prevention intervention programs, and 10 intervention related to HIV linkage care and management of ART that are also going to be modeled. Next slide. As part of phase 2. And as part of phase 2, we are almost midway. We have done with the PrEP modeling, and we have pre-results that are ready for presentation. Then on costing, on the cost ingredients, I will ask Vale to come in also.
Thanks, Simon. So the costing outputs, as I said, where the costing was led by a health economist working in Zimbabwe with the Ministry of Health as a consultant. And so these costing outputs were derived using an ingredient-based approach with inputs coming from source documents and stakeholder consultation. The commodity costs were collected from various documents, including National Strategic Plan, grant application documents, quantification report. Implementing partners were consulted on cost input, especially for outreach and community mobilization cost. And guideline documents and national algorithm were determining kind of intermediate step and procedure for each intervention. And consultation was held with Ministry of Health to validate inputs, costing assumption, and implementation arrangement. So no kind of like, as part of this project, there was no new costing being done, but mainly using costing estimates already available. But just as an example, I'm just going to go through the costing for PrEP in adolescent girls and young women. And you can see that in terms of drugs and reagent, what is costed is HIV test and the PrEP drugs. In terms of human resources, the HIV test meant time for HIV testing, time for the risk assessment, and for the adherence counseling, but no operational costs are assumed for facility intervention. So if they stay 1 year on PrEP, this would cost around $103. But at the moment, what the Ministry of Health is saying is that actually in this population, the retention is a lot lower. So with women staying around 4 months on PrEP. So I just wanted to share with you some discussion that we have been having as part of this project. And so something that is kind of becoming apparent is that so averting one HIV infection does not averting many years of life with disability, compared, I guess, to the past, as the global burden of disease 2019 weight for HIV/AIDS with antiretroviral treatment without anemia, that's the kind of category, is 0.078. And now, as you all know, in Eastern and Southern Africa, almost 80% of all people living with HIV are accessing antiretroviral treatment. So they will be given this way. And so this is kind of like ignited some discussion between the HIV Modeling Consortium and the Institute for Health Metrics and Evaluation and people living with HIV as to whether actually the definition used to estimate this weight is appropriate. As at the moment, it treats it as occasional fever and infection. The person takes daily medication that sometimes causes diarrhea. And I think especially the community living with HIV is finding that this doesn't kind of fully reflect actually the burden of having HIV, especially related to the stigma still attached to the disease. And this is kind of linking to what Marcus was presenting. When we start preparing for the output that we were asking the different models, something that we noticed was that actually there was variability in how the different models calculate the years of life lost. And this was actually highlighted already into a previous paper by the HIV Modeling Consortium across different countries, but most of these models are actually the ones that are involved in Zimbabwe. And so what was agreed was to calculate future years of life lost at the calendar year of death with years of life remaining using gender-specific life expectancy, discounted by 3% per year. I think we need more discussion about the years of life lived with disability. These, at least for some of the model, is not their standard output. So I think it's going to be interesting to compare how this output compare to what they would usually produce when they cite years of life lost. And then Gesine asked me to share with you some practical lesson learned, and I feel like I'm not sure I'm kind of entitled, given I've not worked for as long as Gesine, at least in this field. But what we've been finding as part of the MIPSA Zimbabwe was really that involving both relatively junior staff and more senior one within your national stakeholder organization has worked quite well. As the union staff has kind of more time to dedicate to the project, and the more senior one had the authority to kind of give permission. Working with in-country health economists has worked quite well with us because he really knew the sources used by the Ministry of Health and kind of who to ask. And then really making sure that it's a partnership with national stakeholders. So for this reason, actually all the MIPSA sub-project are co-led by members from the academic field together with Ministry of Health and National AIDS Council. In terms of future challenges, probably one that should decide is that how to deal with likely merging of HIV and non-HIV funding in the future, and the fact that different cost-effectiveness threshold would apply then. And finally, I would like to just thank people that helped me put these slides together and all the team involved in MIPS at Zimbabwe. And thank you very much.
Thank you very much, Valentina and Isaac. That was very, very informative. And I think it's really, really useful to have not one, but several countries represented here. Can I just ask for questions on or comments on either of those presentations? We unfortunately have to keep it quite short now. Anyone wants to add? Query? Okay, I take it there's no more questions. Were there any questions on the chat? Oh, sorry. Oh, yeah, absolutely.
Hello, good morning. My name is Makini Booth from UNAIDS Mozambique. And I just had a question, and maybe I missed it, but was wondering when you were working on the PrEP costing, whether or not you've also considered using the PrEP-It tool that was developed by Avenir Health that also has a costing component or costing module. Thank you.
That's a question for Vali and Isaac, I think.
Yeah. So I think I don't think that was used, but actually Avenir is involved in the collaboration as John Stover is part of it. At the moment, has been using actually the data from the Ministry of Health. So I don't think it has been used, but I'm not the person who did the costing. So yeah, I'm not 100% sure.
Yeah, I have a feeling it might have been PrEP-It because that does include the health systems cost, et cetera, et cetera. Yeah. Okay. Any other questions?
I think Isaac might want to come in.
Isaac?
Thank you. For costing of the National Strategic Plan, we used also the PrEP costing. Actually, we used different models. The other model that was used for PrEP is the PrEP-2, and it was a hybrid approach that was used for NSP. So for the cost that have been actually aggregated and collected for the MIPSA, it included also the unit costs that were used for NSP and for Global Fund application, where we had several consultants. So I believe some of the assumptions that were brought in through the Avenir Health PrEP-2 were also considered in our cost that was collected by health economist Tami. Thank you.
Thanks. Okay. Thank you very much. With that, I hand over to the next session. Thank you very much.
And I hand over to Matt, and we're going to where HIV policy, advocacy, and economic analysis come together on inequality.
All right. Hi, everyone. Let's see if I can keep to the time that I was allotted, as I've been told to. So thanks everyone for really interesting presentations thus far. And as we think about kind of the implications of this for policymaking, I will say at the outset that I am not a health economist nor any sort of economist at all, but instead a political scientist who's somehow snuck into your realms, who spends most of his time thinking about how to get politicians to move in different ways. So I'm going to talk a little bit here, I think a bit as a challenge to the field to think with us about how we tackle this very big shift that we are trying to move within the global AIDS response toward attention, not in just a rhetorical way, but in a very practical way to the implications of inequality in the HIV response today. And so I'm going to talk about why, and I'm going to talk about some of our big questions, and then I'm going to talk about what we need, I think, from health economists. And I could do that better with another slide. Is there a different button I should put? Ah, here we go. Great. Okay, so here, here we are in 2023, but it's just worth remembering that we're in 2020, not too long ago. And there we, really have without a cure, without a vaccine, achieved remarkable outcomes. And I kind of remind those, especially those who have not been in the field for 20 years, that not long ago, the idea of 90-90-90 was kind of a crazy, like, what are you talking about, people, right? And now we've not only modeled it, but we've achieved it in many countries. And in fact, you also see the remarkable effects of HIV treatment and its effectiveness. We just, as a reminder, by 2020, we actually globally achieved the effectiveness that 90% of people on treatment were virally suppressed. And that is a remarkable measure of quality, right? There's actually not very many places within global health where we measure not only coverage levels, but actually is the intervention working the way it was imagined, and it is. So that is very, very good news. But of course, you all are also familiar with the fact that we did not hit the 2020 targets, and we are not currently on track to hit the 2025 targets, and we should be deeply worried about that. And so the core question is kind of why, right? Not only did we miss the mortality target, but we significantly missed the incidence target. And just to say it out loud, we see worrying trends in many parts of the world, right? And so this is last year's Global AIDS report. And it shows that actually we're seeing rising new infections in far too many places. And so the question kind of becomes, how can we have achieved what we've achieved, but also see the outcomes that we're seeing? And the answer, kind of the core argument here behind the global AIDS strategy is that, risk of HIV, effects of treatment, effects of prevention interventions are of course not just normally distributed and equitably distributed, right? And so the core argument here, right, is that while the science of HIV is remarkable and we have achieved remarkable things, it's actually because of that success that we actually see, significant disparities and growing disparities when it comes to who's been reached and who has not. And in fact, the argument is that we've exhausted the ability to think in total terms, in absolute terms, and have the effectiveness that we had 10 or 15 years ago, right? That where we could count on the idea that if you increase total coverage, we will have a major impact. That was true for most of the history of HIV, but the argument is that that is no longer true, right? And if that is no longer true, and if we accept that, then how do we actually shift how we think and say that success may not look like the total number of people, it may not look like total coverage levels, but instead, what if success looks like how small the gaps are? And it's a contention that says, look, we think that if we close the gaps, if that's where we focus, everything else will follow. Because at this point, we've shown the effectiveness of the interventions, we've shown the effectiveness of the response, we have shown what that looks like, and yet some it's working for and some it's not. And so if we focus on those gaps, and even to the effect of limiting, right? If we put fewer people on treatment, but those people we reach are the right people, that might matter more than getting more and more people on treatment. This is the question that's ahead of us. So to close those gaps, the question is kind of how do we do that and how do we focus on this? And as we think about that, one of the realizations is that, of course, doing what we've done before may not actually, harder and more and with more focus, may not actually deliver the outcomes that we're looking for, in part because inequality is about power, right? And so just doing the same thing won't necessarily deliver the different outcomes. So a challenge, can we move from kind of the what to the who and the why? So this is the most recent UNAIDS data when it comes to overall, where are people living with HIV, right? And the vast, vast majority are on treatment and are virally suppressed. That is remarkable, well done. And we should see massive drops in new infections, right? Because it's working. And the fact that we don't tells us that we haven't reached the people who are the most needed to reach, right? That's the challenge, right? So who's in those orange and red bars up there in terms of people who don't know their diagnosis, right? Don't know their diagnosis, or who know their diagnosis and are not on treatment, right? We're not super worried about the people who are on treatment and not virally suppressed because actually it's a tiny, tiny fraction. We're very worried about the others. And then we're also, of course, worried about the new infections in the last 6 months. And so who are those folks? What do we know and what can we do? And what can you all in this room kind of contribute to that analysis? Well, a couple of things that would be very helpful. So one is to say, of course, we see a wide variety of axes across which inequality exists. So these are just, you know, a handful of examples. But as we drill into this question of why aren't we having the impact that we want to have, we can look to Brazil, which has rising new infection rates. But it doesn't have rising new infection rates among all people. It only has rising new infection rates among the Black population. And so that says to us that there's a structural challenge there that we've got to actually tackle. We can look at gender and see the disparities between girls and their counterparts. We can look at sexuality in key populations, and we can look at economic inequalities and think there. But we also have a lot of evidence that actually intervention is deeply possible here, right? So sometimes, and I think, Marcus, you gave us a little bit of a challenge, which is how can you articulate this in a way that's really clearer? Because sometimes when they hear inequality, the argument is until there's social justice, we'll never end AIDS. But that's actually not the argument at all. The argument is, what does an inequality-sensitive AIDS response look like? What would it cost? What would the benefits of focusing on inequality versus not doing so be? These are the challenges in real life, because, for example, we can see that actually there is a biological, you know, reality behind, for example, men who have sex with men that are at higher risk of HIV everywhere in the world because of a variety of pathways of what's the most efficient transmission methods. But in Thailand, gay men are 12 times at higher risk, but in Malaysia, they're 72 times at higher risk. That's an intervention challenge, that's a policy challenge, that's a criminalization challenge, and so we can kind of dig in there and understand. All right, so here's just a few examples, right? So this is, you know, an analysis that was was in last year's, and I'm gonna forget who did it, and this is horrible of me. So I hereby apologize for the apologies of, this is James, somebody's analysis, I'll tell you later. But basically it shows, right, that actually overall, of course, this is East and Southern Africa, you've seen a remarkable dip in new infections. But among men who have sex with men, you've actually seen no dip in new infections in Southern Africa over this period. And we should be deeply alarmed by that, right? That tells us something about what's going on in the regional dynamics. And it also helps explain why it is that we're not seeing more rapid declines. This is a set of papers, done to say, okay, what's going on there? How do we understand this? And so this is a piece by Carrie Lyons and colleagues that actually looks at new infections among men who have sex with men in a number of countries and shows that actually in contexts of criminalization, right, what we see is higher differences between the HIV prevalence HIV incidence rate among men who have sex with men and all men. The gap between them is radically higher in contexts of criminalization. And so that tells us not only do we need to focus on criminalization, but we also need to focus on all of the services around it. We probably need to do something very different in contexts of criminalization than we do in contexts of non-criminalization. And that potentially there's a real achievable kind of action there, because we can see that inequality, we can measure it, and we can act on it. In contexts of criminalization, by the way, all of the 90s are actually lower. But what we also see is that actually investments in non-discrimination policies and other institutions have had a measurable effect. And so countries that have invested there, that have these kind of non-health sector interventions, actually achieved better in the 90-90-90 period. So that is leading us to think a bit about mechanisms, right? And this is where I think, you know, we need some more health economics thinking, which is to say here we can see within, you know, that spectrum where we can understand the mechanisms through which perhaps new infections are actually happening due to kind of criminalization contexts, and we can design interventions. But can we do something similar across other metrics of inequality? Or can we just turn off the screen? Okay, great. Even better. So in this, you know, in this context, one of the things that we're thinking a lot about is this question of wealth inequality and poverty. And there, of course, is, and I'm kind of arguing here that there's kind of been three phases, right? That a lot of the early work, much of which was done by health economists early on, actually showed the dynamic of actually wealth almost being a negative, right, early on in the period, because, you know, the middle classes and the upper middle classes had higher infection rates. But of course, that was in a context of 0.6% global treatment coverage. And then that became far different in terms of the outcome when we got to 25%, and the evidence became really mixed. But we don't have a lot of evidence right now, right? And so my hypothesis, of course, here is that in a context of 75% treatment coverage, we probably have a very different dynamic when it comes to the interaction between wealth and protective status of HIV, probably because of who's accessing and who's not accessing treatment and other things. So since 2010, all of that has changed. What's going on there? Can you help us kind of dig in there? Can we look a little bit, especially at intersections? One of the things that we think is challenging is that we talk a lot, for example, about key populations, but it's not all key populations that are at higher risk. And in fact, we think there's an interaction between income level and key population status that actually you could design interventions around. This is just one kind of slide here. This is from the Fast Track Cities project, looking just quickly at DHSs and FIAs, right? And showing actually some really interesting data when it comes to slums versus non-slums. Now, some of this data is a little bit old, right? But it of course shows that you've got some real heterogeneity in terms of the gap that some countries, the slum dwellers have far higher HIV rates than non-slum dwellers. But in some countries, the difference is actually small. And in a handful of countries, it's reversed. So that's really interesting. What's going on there? Can we learn from one into the other? I think there's something here about the effectiveness of the AIDS response that if we judge here, we might actually see an association. And this, by the way, is also not disassociated with progress overall. Another question. What's going on with income inequality? So one thing is the question of poverty, right? And that's one question. But actually, we've also done some work just most recently led by John Ataguba that looked to see, is there an association? Now, this is only an association, right? Is there an association between income inequality and HIV mortality rates, HIV incidence rates, and also COVID mortality rates? What we find is that there is. More unequal countries are struggling more to bring down their mortality rates and bring down their incidence rates. That leads us to the question, can we do the same kind of mapping of what the mechanisms are there and actually think about what the interventions would be in contexts of high inequality? So I'm going to close up in just a minute, but just to say that the kind of theory here, right, is that there's an individual level action, but there's also probably a socio-political level action, and we could design pieces of both. And sorry, I would be remiss if I didn't talk about between country inequality and the work by Marcus that I had not caught and just was reading. That's fantastic. That shows the impact of the AIDS response in reducing, actually pretty radically, between country health inequality. But in fact, we still have huge challenges. And so if we look at PrEP coverage, just for example, it was only in quarter four of 2021 that South Africa had more people on PrEP than the United States did, right? Absolutely initiated. This is really bizarre and dangerous and worrying, right? And so we are seeing this more and more and more. And so as I think about the kind of description that we've had today, in which we talk about transition, this might well exacerbate. Transition could very well exacerbate it. And of course, this decade-long reduction, I think also helps, this decade-long difference helps explain why people in San Francisco and London and New York who are at high risk of HIV have seen their rates plummet in a way that they've not done in the same way in Johannesburg and in Kampala and in Nairobi. And so how do we fix that in the near term? So key issues, within country pieces, right? What's going on there in the near term? Can we kind of look a little bit more at mechanisms? But for you all, what are the costs, benefits, effectiveness of closing gaps? Can we look at that? Because I think it's not just about how much, it's also about where and how, and what kind of a set of interventions, how much more effective could a more equalized response look like to a less equal response? And I think that's going to be the key question going forward. And then at the international level, what are the costs of delays of access to services? I'd be really interested to see an analysis that looks at the epidemiology together with the costs of what has been the cost of delaying PrEP initiations so far. Right now, CAB LA is rolling out across the north. What's the costs of delaying? Are we going to be 10 years before we see that really hit some of the most urgently needed people? What are the costs of that? Because actually right now the conversation is, boy, that's really expensive. But I haven't seen any good modeling that says, boy, delaying that is actually going to have a long term. So you're going to give it to me and that's going to be great. Okay, I'm going to leave it there. Thank you all. And thank you for inviting me, Marcus. Over to you.
Thanks so much. That was really interesting, Matt. So like you, I am also not a health economist and also managed to sneak into this field in this realm. And so I'm very excited to be here. Thank you, Marcus, Gesina, and the Global Fund for inviting me to speak. My background is actually in programs and partnerships, and I lead the foundation's sustainability portfolio on the HIV team. So to give you some context, that's the lens through which I am looking at this really interesting topic. So I'm going to talk a little bit today about our reflections on the economic impact of HIV, and it's an area that, as you probably know, we have supported for a long time and been involved in for a while. And it's very important, this area, especially today, given where we are with the epidemic and also the potential decline in large-scale donor funding in the short term and medium term. And obviously, as we've talked about, this work contributes very much so to the dialogue around sustainability, and therefore the need not only to push for continued investment in HIV, but more efficient investment, and therefore sustainable transition planning. So I'll talk to our thinking in this area with, which is still iterative. We are still refining our thinking and having it be informed through our collaborations with all of you, with key partners, governments, Global Fund, PEPFAR, UNAIDS, and others. But I'm going to talk not only about sort of the evidence and the data that we think is still needed, but more importantly, on the translation of that evidence and data into action from a programmatic and advocacy perspective. And this came up earlier, I think this morning, when Daniel mentioned sort of the data is there, but how is it really being used? And is it being used? And why is it not being used in the way that it should be? And I think it's important for us to be generating this kind of evidence and data that informs the sustainability agenda, but also makes an impact on the epidemic itself by helping to make programs more effective and efficient. Okay, so just to give you some background in our involvement in this area, here's a timeline of the many activities that we've been engaged on this topic, starting back in 2018. When we convened experts in the field to talk about the economic impact of HIV and how we could help make the case for continued investments. As a result of that convening and through the incredible work of Marcus and Gesina and others, we developed the economic impact of HIV framework, which I'll talk about in a minute. Thereafter, there was work done to summarize the evidence on each component of the framework into policy briefs, which were meant to be used to influence decision makers like ministers of finance. Unfortunately, because of the COVID pandemic, a lot of those plans were interrupted. That said, in 2022, there was a webinar that was held to disseminate the results of the framework. And in 2023, there were a couple meetings that were held, one hosted by PEPFAR with ministers of finance on the heels of the World Bank Spring meetings, and then a convening that we held in London as a follow-up to the 2018 Portugal meeting to take stock of where we are on this issue today. All the while along the bottom there, you can see that we have also been engaging with the AU and with ALM as well, as they have developed their Spend Enough, Spend Well framework and their health financing tracker as well. So that brings us to today, where we hope to continue the discussion and find opportunities to collaborate. So a big thank you again to Marcus and Gesina on their work leading the development of the economic impact of HIV framework. The framework highlights the social and economic impact and trade-offs of investments in HIV, and it was meant to be used, as I mentioned, as a tool targeting country leaders and policymakers when asking them to increase their domestic investments in the HIV response. It was good work. It used a lot of academic rigor. There were policy briefs, as I mentioned, that were developed out of the framework, and I think they did serve their purpose at that time. There were also some research gaps that the framework highlighted and identified as areas that still needed further analysis and evidence. And we brought stakeholders together recently to examine those evidence gaps and start to prioritize the ones that we think should be addressed first. But before we started to go down that road, we wanted to first, we realized we needed to first understand what exactly it was that decision makers needed in order to make the case for continued and better HIV programs and investments. So we asked this of various stakeholder groups, including donors, advocates, economists, country program experts, to hear what it is that they were hearing from their key stakeholders, whether that was ministers of finance, ministers of health, Congress, country governments, et cetera. We then re-examined, as I mentioned, the economic impact of HIV framework with an eye towards whether it had served its purpose or does it need to be refined in some way. And then we looked at the evidence and research gaps that the framework highlighted and tried to prioritize them. And I'll show you the results of that exercise shortly. And then we asked the important question of what are those barriers to translating all of this economic evidence and data into action from a programmatic perspective as well as an advocacy perspective? And really, how can the evidence support the programmatic and advocacy agendas? And then finally, what are really the next steps to moving all of this forward? So what are the asks? So here's what we heard in terms of the asks. What do decision makers need to enable more money for health and more health for the money? And we heard 4 things. First, we heard that they need to see the impact of HIV investments on health outcomes and on economic growth. Secondly, they need to see the cost of inaction. So what is the impact of decreased donor funding? What's the so what? Then they said, we need to see expenditures. So how is the money that is currently being invested, how is that being used? What did it buy? What were the outcomes? There's an accountability factor there. And finally, there's a lot of interest, as we've discussed today, from decision makers regarding integration of HIV and the primary healthcare system. And so what are the implications of that integration on cost and on outcomes as well? So then, as I mentioned, we re-examined the economic impact of HIV framework, and it was agreed after discussion with stakeholders that the framework is in fact still useful and that it has many strengths, including how comprehensive it is, but that it does need to be refined, especially to include post-COVID context. So more on the economics, more on the financing, and potentially even broadening it beyond HIV. And it needs to be communicated and packaged differently now with layperson language and for an audience that doesn't necessarily understand health. So here is the results of that evidence gap prioritization that we conducted. Again, this was with just a small group of key stakeholders that we brought together. And here's what we were told by our stakeholders that should really kind of bubble to the top of the list in terms of those evidence gaps that should be prioritized. So first, the fiscal and programmatic implications of integration of HIV and NCDs. And then the impact of systems level investments. So understanding their costs and their efficiencies. Thirdly, allocative efficiency. So the comparative cost effectiveness and allocative efficiency of different interventions. And then the health and economic growth impacts. So health impacts in terms of inequities, as Matt talked about, as well as the economic growth impacts in terms of human capital and productivity effects, which a lot of that data does exist actually, but I think there was an understanding that there needs to be more and more targeted data and information. And then of course, post-COVID implications, financing implications. There were also other evidence gaps that bubbled to the list, things like understanding the cost and implications of HIV prevention funding gaps and primary healthcare financing, amongst others. Okay, sorry, I know this is a very text-heavy slide. So here we tried to then describe what the barriers are to translating some of that evidence, particularly into programmatic action. So we heard a few things. First, we heard that data needs to be user-centered and demand-driven. It should be co-developed and co-designed by users. It should be timely and accessible, and all too often data is released so much later that it's no longer valid, frankly, and can't really be used in the way that it should. It should also be curated at both the national and subnational levels to be most useful. We also heard that there are some barriers and challenges from a capacity and data use perspective. So data should be tailored to the needs of the user, so a country's needs, for example, and it should be gathered in partnership with local partners and universities. Too often, there's an extractive relationship rather than a collective relationship. Data also needs to be communicated in a non-technical language, as I mentioned. And of course, you can't talk about all of this without talking about strengthening the public financial management systems. And oftentimes, global level data is actually more readily available than country level data. And so countries really need to be able to monitor how that data is used. And there are some initiatives already in place and underway. So for example, it's really critical for country data to make it into the Global Fund PEPFAR resource alignment initiatives that are currently happening. But overall, the point here is that PFM plays a really big role in the ability of all of this data to be effectively translated into action. And then finally, we talk about the need to translate evidence from a supporting of the advocacy agenda. And so we talk about it in two ways. First, from sort of how to make a compelling argument using the data, but then also talking about sustainable transition planning. So framing matters. And we were having a sidebar conversation about this earlier. You know, we shouldn't be framing HIV as a legacy issue, but rather as a platform to build upon for others to join. And at the end of the day, it is still an infectious disease. So while we call it a chronic disease, it's not wrong because we have lifelong treatment, of course, now available. It is still an infectious disease, and we can't lose sight of that. The cost of inaction has also shifted. So it's no longer about mortality per se, but rather those medium-term morbidity and mortalities that may happen outside of a political term. And there's also a question of whether we should have domestic resource mobilization targets or not. And if so, what are good targets? What might that look like? And finally, there's a need to bring the art into the science of decision making. So using evidence and data and economic data at the right time with the right messaging and framing and with the right people to truly make an impact. There's also a need for using evidence to inform sustainable transition planning. Countries are in a very precarious place now, as we know, post-COVID, with high debt burden and economic shocks from the pandemic. So we need a realistic, differentiated transition timeline that really looks at where a country is economically and how to align incentives, which we heard from Mark earlier this morning, for continued and more efficient investment in HIV. And the last thing I'll say is that sustainability goes beyond money. And so when we're talking about translating evidence into advocacy or action, it's really not just about the money, but it's also about aligning donors and countries on things from a programmatic perspective as well, things like integration, systems, HRH, et cetera. And finally, of course, there is a need to reset expectations regarding what countries are able to contribute to the HIV response at the moment, particularly in the short and medium term. I just have two more slides. Oops. Did I hit? Okay. So here we highlight the importance of framing the messages, as I mentioned, into a story to decision makers in the right way in terms of three main elements. The impact, so talking about the HIV response, building strong platforms that can support and sustain response to other pandemics. Efficiency, so being able to use the data to tell the story of how we are spending the money well, better, smarter, more efficiently, and getting results. And then finally, sustainability, so that both countries and donors are spending enough and spending well. And all of this is underlaid by, of course, the evidence, the messages, and the messengers. And finally, as we think towards the future and next steps, I think it'll be really important to reflect on the economic impact of HIV framework, prioritize those evidence gaps that I mentioned, and perhaps delve a little bit deeper into understanding and addressing those needs and gaps, and then working closely with stakeholders to action plan and find forums like this one where we can raise these issues. And I just want to say a quick thank you. They always say that if you didn't take a picture, it didn't happen. So, oh, I guess my last slide's not in there, but we took a picture. I just want to say thank you to all of those who have helped us inform our thinking in this area, and we look forward to our continued collaborations. So that we can really sufficiently demonstrate the economic and health impacts of investments in HIV, particularly as countries start and donors start to think about how to sustain the response over the next decade and beyond. Thanks.
Thank you. We are coming to the end of our pre-conference. We have run out of time for the discussion we meant to have. I'm coming out of here. I had times I got bored with the economics of HIV because it was pretty much sitting off the autopilot and driven around this huge and agenda of scaling up of treatment towards ending AIDS, large aggregative modeling. And today we have seen that this is that this mode is that we've moved a lot from this mode with new kinds of questions being asked post COVID, in a changing economic environment, about getting HIV economic analysis to the point of delivery, the implications of the changing shape of HIV in terms of a modeling chronic disease approach, but also refocusing, shifting the focus from getting populations covered by treatment to the populations who are not effectively served by HIV, and the implications this does have for the sustainability and for the equity of the HIV response. If you have any questions that you need to raise, do it now. Quickly. Otherwise, if you have registered for the event, I will be in touch with you, thinking through some follow-up, making the material from this session around this session available. The session rested on many shoulders of people who have been here today, and in turn building on a lot of economic analysis that has gone through this point. Thank you for the Global Fund for funding this particular event. Thank you for all the contributors. Thank you to the audience for attending.